A fi ẹsẹ̀ rìn láti Ọ̀wọ̀ Abẹ́tẹ̀mídé àti fẹ́ẹ́ níbi ibi pálásì ọba yẹn ètò ìṣẹ̀dá lọ́kadà náà táwọn.
Hello, good morning, everybody.
Good morning, ma.
Yes, can we all hear me loud and clear?
Yes, we can hear you. Kindly proceed.
All right, so I'm going to share my slide so we could start. Today is going to be a very exciting day. We're likely going to have more of practical demonstrations of our management techniques. We've got a range, we have a range of techniques we'll be demonstrating, and hopefully we're going to learn a lot based on all what we've been discussing before now. So I'll just quickly go to my slides, shared document, advanced slides. Let me share my screen. Oh, document. All right, can we see the screen? Can you see my screen?
Yes, of course.
Yes, Professor, we can see it.
I've seen it clearly.
Thank you. So like I said, today is going to be about management of non-specific low back pain. Before now, our first module was about understanding low back pain in terms of non-specific. We have been able to go through it very in-depth. We talked about what it is, how to identify it, knowing that it is one of the most common and it takes a lot of impact on our physical self, psychological self, and quality of life. Of course, we talked about how do we assess low back pain in our second module. We demonstrated most of the pattern and how you go about history taking until you're able to get the specifics of this non-specific low back pain. Of course, we mentioned that we need to make our diagnosis. So it's about the diagnosis today we'll be pondering upon. After your assessment, are you sure this low back pain is the disc problem? And is it emanating from the disc or is emanating from the from other structures away from the disc? So we need to know this because it has to guide what specific management we're supposed to do. So for today, I said we're going to be looking at the essential topics under that. We'll first of all talk about what are the evidence-based strategies for managing non-specific low back pain. What are the current guidelines? What are these guidelines? What are they telling us to do and what we should not do, based on evidence? So we're going to be looking at the evidence-based practice. What are we expected to do? And then what are we not expected to do? And of course, we also try to see our diagnostic clarity. How do we differentiate between disc pathology and especially spinal stenosis? I'm sure before now, most of us will have been thinking it is one and the same thing. But we're going to see today that these are two different pathologies and two different entities with two different management strategies. You don't use the same thing for the same purpose. So we're going to look at that. Of course, we want to see how do we use holistic patient care technique. That is, you don't just use one specific treatment. We want to look at the biopsychosocial approach in this management. And of course, today we're also going to be talking about exercise therapy in general. And we're going to be looking at core stabilization, aerobic exercises, of course, some of the strengthening exercises, and our progression plan. How do you progress when you're trying to do exercise for non-specific low back pain? We're also going to talk about some manual therapy techniques in terms of joint mobilization, manipulation. I will see these techniques, what they all involve, and how to go about it. And of course, we'll talk about the different pain management techniques. Of course, we have an array of equipment and tools we could use to manage pain. So what should we do in trying to manage such type of pain, you know? And lastly, we also talk about return to activity. How do we ensure that the patient practically gets interventions that give them full recovery to go back to work and to go back to their day-to-day activity. So ladies and gentlemen, this is what I have packed up for us today, and hopefully we're going to enjoy the rest of the drive for today. I hope most of us here today, we have gone through the first and second module. If you have done, wonderful for you. This last module is going to equip you with how to, you know, get that professionalism you need to function well in terms of back pain management. So, as a way of introduction, I'm just going to dive into the current guideline. Let's look at the overview. In general, I want us to know that our current guideline for management back pain is supported by the NICE guideline. Who has heard about the NICE guideline? What's the full meaning of NICE as acronym? What's NICE? Any person? NICE guideline. It's from the UK. The guideline is what they use, you know, to guide the treatment of back pain in the UK. Do we have a guideline in Nigeria? Do we have a guideline in Nigeria or in Africa? We should understand that these guidelines, they reflect a high quality evidence from various health systems. They emphasize how we should treat the patient, to be very strategic in their function, and to empower them with self-management. Well, NICE means the National Institute for Healthcare and Excellence, you know. So this is a guideline from the UK that it was last updated in December 2020. And you will see that this guideline with that of the APTA, the American Physical Therapy Association of America, you can see this is in America. You have that Dutch guideline in the Netherlands. You have the European guideline. So all these bodies, they have a guideline. But because we're still lagging, the Africa, Nigeria specifically, we do not have any guideline. So it means people are left to wonder, what do they do? How do they go about managing back pain? So we don't have this evidence on our people, and we've not been doing our best to make sure that we do that. So I said this guideline, they focus on conservative, patient-centered care. They try to make sure that we avoid over-medicalization and unnecessary imaging for our patients. So we should note that the guideline, they emphasize that the first line intervention, either for acute or chronic low back pain, is that you should reassure your patient. What it means is, you know, just let them understand this low back pain is a positive natural history. And every person, among every 10 persons, 8 or 9%, that is 80 to 90%, are likely to have this problem at one point or the other in their lives. So it's not a big deal that you haven't back pain, no matter how bad it is. But the good thing is you should just learn how to cope with it and then how to take care of yourself. So reassure your patient they will be fine. It's just an inflammatory phase. So this is also want to stay away. So guidelines say the first thing we should do is to reassure our patient. Number 2, you should advise your patient. And this advice is that they should stay active. You know, before now, the moment a patient presents with first acute low back pain, they hospitalize the patient. Some of them even would put what do you call it, the skin traction, and put a patient not to move at all, which causes more deconditioning and more wasting of the patient's muscles. Sometimes they put the patient for 2-3 weeks in bed, and then eventually patient will not be able to recover as necessary. So you just ask your patient to do what they call an active rest. Of course, don't do any activity that will provoke the pain. But of course, you are not supposed to remain in bed lying down all day. So this is called you advise. That's the second intervention, that is in your first line intervention. Of course, educate your patient, looking at the biopsychosocial understanding of pain. You let them understand this pain does not mean there is a harm. It doesn't mean that structures are damaging, the structures are getting worse and all that. No, let the patient have a better understanding of their pain so that they'll be able to cope with it properly. And of course, we talk about you give them some exercises, and these exercises will be tailored to their activities. So it's what we call graded activity. You put gradually, they start doing some few things, not just start jumping and all that. So all these, you try to tell your patient how they should be able to maintain their stress level, how they should be involved in their self-management, how they should reduce fear of activities they are doing. So all these are things we would like to know that this is what is being advocated, and this is what the guidelines say we should do when we see our patient with first line, with first episode low back pain. Of course, what does the guideline tells us about manual and psychological interventions? They say we should know that manual therapy in general should just be used as an adjunct. What do we mean by an adjunct? That you don't go and manipulate a patient that is the only therapy you want to give for non-specific low back pain. It's not done. So it should be used with other therapies together. So it should not be used as a stand-alone. Please, let's have this at the back of our minds. Manual therapy should not be used as a stand-alone therapy for patients with NS, LBP. Of course, we should also know that CBT, or psychologically informed therapy, should only be used for patients with persistent problems. When your low back pain is becoming persistent, then we should know that we have to introduce a CBT, or psychologically informed therapy. So this is what we are, the guidelines are all advocating. And of course, as said, when the patient is becoming a chronic situation and then having complex scenario of problems, we should now emphasize multidisciplinary rehab. That is, a patient might need to see the orthopedic surgeon, a neurosurgeon, an occupational therapist, a physical therapist. So it should be multidisciplinary rehab, okay? Don't think only you can handle all cases. So when you're having a complex scenario of a patient, so you must learn how to diversify the therapy. You don't keep it with you alone, because we want the patient to get the best. So of course, the guideline also mentioned about pharmacological and imaging guidance, that we should know as of the moment, paracetamol is no longer a first-line drug because it does not really help any patient with low back pain. Unfortunately, very, very unfortunately, some of our neurosurgeons, orthopedic surgeons, they still just give the patient this medication. Do you know why they do that? They want you to have the medication and go back, and then you still come to tell them that nothing is working. They did not send you to any therapy, but they want you to know that nothing will work except the surgery. So they will still write for you to go buy a paracetamol. Of course, it may not come in the name of a paracetamol. They might write for you, go get Anarol. Anarol is a paracetamol that is inside. They can write for you to get Majestic. It's also paracetamol that is embedded. Excuse me. So please, let's know it is not what is being advocated in the guideline. For any reason, people are doing that. They just want to misuse the patient or for some other things for who God knows why. Of course, NSAID is what is being advocated, but those drugs must also be used carefully. We should know that the drug, all they need to do, because inflammatory reactions are likely to be going on, so you want to use some drugs that will help you reduce inflammation. So you must use the drug carefully, and you must be able to understand if the patient does not have any liver disease or kidney disease. So before you use any drug, so we should use with care. It mentioned that we should use opioids like morphines, okay? We can use them if every other of these NSAID fails. A patient can get high sensitization of pain with heavy irritation. So such type of patient might need morphine or some type of pethidine, perhaps in injection format or oral morphine. So there is no harm as long as the patient, you will not allow them to get addicted to it. So you use them for a very short time. That's why they say for short term. So it is allowed. But unfortunately, your doctors will not want you to have that, because if the pain reduces, the patient will not agree for any surgery. As for the imaging, MRI and co, the guideline says, as long as you have not been able to identify any red flags, there is no point sending your patient for imaging. It's just going to cost the patient more, okay? But back home here, I've got to understand that our patients, if you don't send them for such things, they feel as if you really don't even know it. So what you need to do is to discuss with the patient, let them to understand the reason why you want to do that, the imaging is being done, and let them know what are the expected outcome of this. And then the imaging is done, what are the next line of action? That if your image is done and it's not going to change how we're going to treat you, what's the essence of doing the image? So you give the patient good education and enlightenment about it. And if they still require it, then you can write it for them to do it. That's called the patient preference. So you don't push the patient. So lastly, these are the issues that have been discussed generally in the guideline. I've been able to summarize them so that we can now know, based on the current evidence, these are the information that the guideline wants you to know. That, of course, we should use exercise therapy. Of course, it should be graded and gradual, and then it should be tailored to the program, to the patient need. We should not use manual therapy as a standalone therapy. We should use it in conjunction with other therapies. Of course, you will see that the guideline was silent about the use of other non-invasive therapies like, what do you call it? Like acupuncture, you know, most of our shortwave diatomy and so on and so forth. The guideline was quiet, not because they did not talk about them. They did talk about them, but they said there are no convincing evidence we should use them. So you should use those ones when there is a patient preference. Example, a patient tells you he wants to, if you could do acupuncture for them, then you should use that. But acupuncture is not recommended as any first line or second line treatment for low back pain, of course, but when patients request for them, you can do that. Of course, you know it's also not going to be a standalone therapy. So having discussed that, I want us to go into our diagnostic certainty. So this is where our treatment is starting today. We want to see what are the diagnostic criteria for disc pathologies versus spinal stenosis. In all non-specific low back pain, is either the patient is coming with a disc pathology or the patient is coming with a spinal stenosis. So we have to be sure what pathology are we working about? Which pathology are we managing in this case? So I say we must have to know why is accurate diagnosis, why does it matter? I say it matters because number one, it will help you to prevent mismanagement. Like I mentioned earlier, the type of movement you will do for disc pathology is an opposite of what you will do for spinal stenosis. So if your patient is having a disc pathology and you're doing a movement of spinal stenosis, you're only going to be worsening the case. And I'm sure most of you will have had some experiences where your patient will come with less pain, and then by the time you finish your treatment, the patient will tell you the pain has been aggravated or the pain has now increased. So that could have been maybe due to mismanagement, okay? You're supposed to do something maybe in extension, but you have done it in flexion situation, then that will exacerbate the symptom. I said it is also very important to get an accurate diagnosis because it's going to guide the targeted intervention. If you get it correctly from diagnosis, then you're going to treat the patient properly because you already know what type of treatment works better. If the diagnosis is wrong, you all know that treatment is likely 100% going to be wrong. And of course, if you get this diagnosis from here, you will avoid unnecessary imaging or any need for surgery. So we're going to see how these things work. And of course, when you do that, you will find out that you have been able to enhance the patient's education about his condition, and then the outcome is also going to be better. So let's start by looking at the diagnostic criteria for disc pathology. Here, I started by saying low back pain with or without leg symptom is commonly encountered in physiotherapy. We all agree with this statement. And therefore, differentiating disc pathologies from spinal stenosis is crucial for accurate diagnosis, clinical decision-making, and tailored intervention. Now, let's look at what is the disc pathology. I said disc pathology could be defined as any pathology causing pain in the back due to bulging of the disc or herniation of the disc, extrusion or sequestration of the intervertebral disc. What I mean here is that these are the different levels of pathological destruction of the disc. The disc pathology usually starts by bulging. When it bulges, it shows that there is no any breakage between the annulus fibrosus and the nucleus pulposus. The annulus fibrosus is the hardened ring that covers the whole disc. The outer ring is what you call the annulus fibrosus, while the liquid form of the nucleus is what you call the nucleus pulposus, which is in the middle. So when that swelling begins to push the outer ring, is what you call a bulge. But at that point, it has not broken down to the environment, so you call it a bulge. You could also have a herniation. Now, when this bulging becomes so high, it can begin to break down the annulus fibrosus, where the nucleus pulposus will begin to come outside. That's herniating out. And that is also what you call protrusion. Okay? You can have protrusion or herniation. It's the same thing. Now, this protrusion, the moment it begins to show out itself, that's when it's a protrusion. And this protrusion can get so bad that it will spill out the disc material completely to pour outside, and that is called an extrusion. It has left the body of the annulus fibrosus. Now it is either pouring on a nerve root or on an intervertebral disc space. So the last phase is when you have a sequestration, that disc is completely ruptured. The disc is no longer showing, has lost all the fluid content of the nucleus pulposus, all right? And has lost all the elasticity of the annulus fibrosus. That is called a disc sequestration. That's the last aspect of the pathological damage of a disc. Now you can see all we're saying here is about the disc. Now, if this disc herniates and then it extrudes on the nerve root, it's also going to cause what? A closure or narrowing of the nerve root canal or intervertebral canal. Okay? So it means there's a possibility where the nerve roots or the discs can also lead to what? Some form of spinal stenosis. But we want to say it much more when we move in. Let's understand that the disc is a specific pathology, that all the problem is emanating out from the disc. Let's look at the other one, which is a spinal stenosis. In spinal stenosis, it just means narrowing of the spinal canal or the foramen leading to nerve compression. Now, what would have led to this narrowing of the canal? It could have been due to wear and tear, that is degenerative tendency, showing that there is what? Maybe likelihood of aging process, which is collapsing the spinal canal or the vertebra itself, without consequences even on the disc. So we're going to see this as we also move. So you will see that the pathologies here, they both differ. I said the disc clinical criteria, for you to understand that this disc pathology, it has its own clinical criteria that the patient is likely to present with. Most often, clinically, disc pathology happen among young to middle-aged adults. So in disc problem, you see it between 25 to 55 years or much younger than that. So it's usually within the young adult age rule. You don't see it in the elderly for the disc problem, okay? And the disc problem always present clinically as a sudden or subacute onset. That is, the pressure will always tell you he was fine hours before the affectation. Like I mentioned in the last class, that we had an engineer who went to his field to supervise a road construction while the governor is supposed to flag off. He just drove to the place and then he realized he could not come down from the car, But before you know it, some of his close relatives are beginning to say it's a spiritual attack. They don't want you to see the governor. Of course, the patient came to me. I let him understand that, look, as a 35-year-old man, you are just having a disc problem. So this is a very clear and clinical scenario, okay? So we should understand that disc pathology, it wasn't with sitting, bending, and coughing. So anything that will increase intra-abdominal pressure, it was going to increase the pain in the disc, okay? And usually, the clinical criteria for disc pathology shows that it is usually unilateral radicular problem. The symptoms are unilateral. It's hardly that it is a bilateral situation. So this is how it comes. Now, the physical findings, if you have a disc pathology, is that you're going to have limited lumbar flexion. You find that when the patient wants to go down, the patient will have a point where it will get hooked up. I will not be able to go down. So that's limited lumbar flexion. But you will see in the elderly people, when you ask them to flex their back, they will flex. Their flexibility is so good. So that is not Dick's problem. So, but when somebody wants to flex and it tells you, I can't move from this point, it's likely a lumbar, a Dick's pathology. And we say for Dick's pathology, there's usually a positive SLR and slump test. We have done all these tests in our last class. So we see that they are usually positive. Of course, the dermatomal and motor supply, the sensory and motor loss is usually there with Dick's pathology because it's likely going to compress on a nerve root, okay? And that gives you, there will be myotomy, weakness, and reflexes changes. So all these are things you are likely going to see in physical examination. As for imaging, when you do the MRI and some tests, you will find out that there is a herniation, okay? Either a bulging or herniation of the nerve roots that is contacting the disc that is contacting the nerve. So you will see that this is where the irritation is coming from. And most time, the provocative test will show you that there is a positive SLR between 30 to 70 degrees. That pain will come up again. And then SLR, that is SLR, and this shows you the disc problem. We did this test last class, and we said this cross SLR is highly specific for a disc pathology. I don't know if you can much more. Can you see the discs I'm showing here? Is the image clear? Can we see the image?
No, sir.
No, sir, it is not seeable.
No. It's not clear.
Okay. Let's see. I think I've been yeah, okay. Okay, is it good like this? Can we see?
Yes, clear.
Yes, sir.
Good. Now I want us to pay attention to the image on the left side first, which is the normal disc. The disc, you can see it is the structure between the two vertebrae. In this T2 image, it shows like a whitish color. It is what divides between two vertebrae. That's why we call it the intervertebral disc. It serves as the shock absorber that does not allow one bone to be touching the other. Now, between the disc, you will see the height of the disc and the width. This is said to be normal disc. Now, that's your spinal canal running down. Look at it, whitish. The spinal canal. Your spinal cord, where does the spinal cord stop? At what level does the spinal cord stop?
L2.
Beautiful, L1, L2. So you can see that it is not here. What do you call this vertebra? This one, can you see my arrow showing? Is it showing? This one. I'm moving my cursor. Is it visible?
S1. Visible, visible.
It's visible, yes.
Yes.
So this vertebra,
S1, sir. Yes.
this vertebra where I'm moving my cursor, what do you call it?
Sacral, sir. S1.
Sacrum. Sacrum.
You can see
S1,
it has,
sir. Sacral.
that's your S1. And that makes automatically this one to be what?
L5.
L5, L4, L3, L2, then above L1. So your spinal cord is not here. So here what we're seeing is the spinal canal. This spinal canal, it has a normal width of 20 millimeters. Usually text will tell you 18 to 20 millimeters. But what we need to pay attention is to see that there is no any irritation, anything compressing this outer covering of the spinal canal here. Now, these are your spinal nerve roots are coming out in the spinal canal. You have them here, you have them, it goes like that. Now, this is your what? This bone here, these are your spinal processes. Look at them here. Okay, these are spinal processes. So in between these and these, you have the intervertebral foramen. Now, what we're trying to say here is, if these are your normal disc, okay, and the other side, which is the right hand disc, can somebody tell me where you think there is a disc problem? There is. What type of disc problem are we looking at? Just tell me, is it at L1, L2, L3, S1? Where is the disc problem here?
It's L5 intervertebral disc.
L5, are you sure?
Yes, I'm sure. The space between L5 and S1.
L5, S1. So where is the disc problem? What type of disc problem are you seeing there?
Disc herniation.
Is it herniation?
Excrusion.
Yes, herniation.
Somebody says an extrusion. Because you need to be sure if it's a herniation, why did you describe it as such? Why do you describe it as such? Why is it a herniation?
I think I'm not so sure.
Yes, you see, when we are reading X-rays and MRI, one of my professors will always tell us that, look, you just have to have an eagle eye with a lion's heart. An eagle eye means just look, pay attention to some small details, and then be bold enough to say, this is what I have seen. That is a lion's heart, okay? So look at it very well and tell me, why is it a herniation, not an extrusion? Somebody also mentioned extrusion. Why is it not why do you think it's an extrusion? Okay, let me show you another one. Let's see if it also differs with this.
Protrusion.
Yes, protrusion is still herniation. I want you to understand those two things. The word is the same thing. Protrusion and herniation, they are the same pathology.
This is neutral. Oh, yes.
So for this, do you think there's also a disc pathology here?
Yes, sir, there is.
So what type of disc pathology?
Disc compression at S1, is it L1?
I just counted your L.
Is this herniation?
L4, L5.
Yes, somebody said L4, L5. Exactly, that's where the problem is.
This herniation
What type of disc issue is that?
Compression.
Excrusion.
Compression.
Disc compression.
Stop saying disc compression.
Intervertebral disc compression.
Disc compression is not a pathology. Okay? Compression is going to be on a nerve root. Listen, let's get this clear.
Compression.
Hold on. Let's get it clear. The compression is on your nerve roots. The disc pathology, there's nothing like disc compression. No. I'm going to show us something now that is all about the pathologies that we've been talking about. I mentioned it starts from bulging, then protrusion or herniation, then I said it goes to extrusion, then it goes to sequestration. And those are the different pathologies that you have. You don't have anything like disc compression. When there's a compression, it's going to be on the nerve roots, okay? Is that clear?
Yes, sir.
Okay. Now, I'm just trying, because this is what we're likely going to see when we begin to pick up the MRIs of our patients. Okay? So we need to know what type of Dick's pathology is this. We all agree there's a Dick's pathology, right? Now, can you see that there is compression on the nerve roots here?
Yes.
Look at the red arrow, what is pointing to you. There's an indentation here. Something indenting here. Is that not? Now, this indentation of the spinal canal is likely to be on a nerve root. So what goes there, it is an extrusion of the Dick's material. Is that not?
Yes.
Yes. So this pathology is likely going to be an extrusion. Now, why is it an extrusion? You have to look at the size of the remaining. If you compare it with the good disc above or below, you can see that this disc size has reduced. Hasn't it reduced?
Reduced.
Yes, the disc size has reduced because it has been what? Pushed outside the annulus fibrosus, is now moved into the canal. You can see now compressing the canal. All right. Now, that takes us to, let's understand what is going to happen. Period here. The first one I said is disc bulging, and that's what we call disc degeneration. When the discs begin to degenerate, it means there's weakening of the annulus fibrosus. It's beginning to weaken. And since this outer part is weakening, what will happen is that the nucleus fibrosus will begin to pour here. Then there's going to be a pressure on the annulus fibrosus, which will be pushing it out. So you can see this is why you call it a disc bulge. Is that clear?
Disc what?
No, sir.
Disc bulging. Disc bulging. Do I need to go back? Are we okay with it, or I should go
We are okay
again?
with. Let's move on, sir.
Yes, please.
Well, okay, sir.
And now, when you have a disc bulging, most of the patients they are going to come with only back pain only. So when you see your patient tell you, I don't have anything in my buttocks, I don't have anything in my leg, my problem is just in my back. So you begin to know that these are the initial region. The patient is having a likelihood of disc bulging. So all you need to do is to begin to see how do you prevent that disc from what? From extrusion. All right? We don't allow it to prolapse, because if it begins to extrude or prolapse, it can break down. So the first thing starts with that disc bulging or disc degeneration. Now, when this disc degeneration continues, it begins to force itself into a prolapse. It pushes the annulus fibrosus far away from its normal position, that begin to go close to the what? To the it's going close to the canal, the spinal canal. So now when it gets to the spinal canal, it can begin to irritate it. And that's where most of the surgeon will be calling it inflammation, that there is a swelling. And this is not a swelling, it's just a prolapse. Is prolapse the same as inflammation?
No.
No. That means there is weakening. It's weakening of the tissue. You know, we talk about hernia, you know, there's a weakening of a tissue, so some organs will fall in. So that's the same thing that is happening here. So when it weakens so much, most of the disc material will move far away and then push the disc out of its normal position. But there is still likelihood that the disc annulus fibrosus is yet to break down. So if this has pushed to the spinal canal, it can begin to irritate the canal, and your patient will present with back pain and leg pain. Depending on the nerve roots it's affecting. So if eventually there's now a breakdown of the annulus fibrosus, that's when we talk about the extrusion. So in extrusion, you have both low back pain, leg pain, and of course, there's going to be what? Hardening. There's going to be consolidation, because those nucleus pulposus that are poured out of it as an extra call it extrapyramidal ground substances, they will begin to hard up. They will now begin to form like a callus-like material in that region. Okay, so that hardening is also going to now be a constant irritation to the nerve root. And this is the reason why patients with extrusion are not likely to come with more pain than patients with disc prolapse and disc degeneration. Because with disc degeneration and prolapse, irritation is likely to be very high on the nerve root because they have not had the fluid material on the nerves. So this keeps just irritating the nerve. But the moment it goes out, you can have pain for that moment, but after some time, your pain is going to be what you call desensitization. It will just be causing more motor affectation, but the pain here is likely to be less. You understand? So if you are now the type of surgeon that always go to the MRI and treat the MRI, not the patient, the moment you see this MRI, you will be wondering, you'll be worried. Look, we just have to do surgery, otherwise you stop working. No, most time patients with this likely going to be having less pain, but more difficulties in activity than pain. This patient in the upper side have more pain than activity. So the last one is sequestration. And this is where in sequestration, they might not even have any pain in their back. This is where when you see the patient, the annulus fibrosus is broken down, nucleus pulposus are all pulled out, there is no any regularity. So there's an irregular disc. Discs are broken down completely. So the surgeon will now say, let's just go and put decompression and fixation. You decompress and fixate the back, it will still not take care of the problem because what has happened and they have not been able to clear it out. So I don't know if we have a good, better understanding now with this. Are we happy with this information?
We are.
Okay.
Yes, sir.
Yes, so, yes, let's make some movement. Let's move forward. So we're going to see spinal stenosis and also see how it looks like. Please put those images of discs at the back of your mind because I'm coming now. We're going to compare with some other images we're going to see just in the near time in spinal stenosis. So in spinal stenosis, we have mentioned is all about a compression of the nerve roots due to degenerative changes. And I said in this spinal stenosis, usually they are in elderly patients above 60 years. And these people, they come to you with pain that is of gradual onset. Their more problem is neurogenic claudication. Neurogenic claudication means there is a motor involvement, maybe difficulty to lift the leg, or they are having paresthesia, or patients will tell you they have these pins and needles. So all those neural involvement are there. Those are the things we call neurogenic claudication. All right? So there is a motor involvement as well as sensory involvement in clinical and spinal stenosis. They said clinically in spinal stenosis, the pain the patient are complaining are most often relieved by flexion. So when they flex their back or sitting, and that's why they said the commonest sign of this is when somebody is doing shopping and they try that they are tired, they try to lean forward on the shopping cart. We know the shopping cart, what you push is, what do you call it? I don't know the name in our local language. What do you shop with? What do you call it?
Trolley, sir. Shopping trolley.
Trolley. That trolley. Yes, that trolley. If you just lean on it and move forward, you can see you have flexed your back, right? For most patients with spinal stenosis, the moment they do that movement, they get relief and they'll be able to move forward and do most of their shopping. But if it's a disc problem, the more flexion you do, the more you are having problem. And that is why you can see that you cannot use one type of treatment to fit all. You must be able to identify what is this patient going through, what is the other patient going through. Okay? I said for spinal stenosis, the moment they flex their back or they sit down, and if they are seated, they don't have problem. But disc people, the more they sit, the more the problem. Okay? And then they say in spinal stenosis is often bilateral symptom. So this is something that is also good for us to understand. So we say during physical finding or physical assessment, you will notice that there is usually a problem with their extension. Spinal stenosis, most of the patients don't like to extend their back because extension causes more pain and the extension will close more of their gap. You know, the moment you extend, you press on the nerve roots again. You are compressing the nerve roots. So we said already they have narrowing of canal. And now when you extend, you narrow the canal the more. So that gives them more pain. Okay, so that brings them to a limited lumbar extension. So you can be seeing that if you have been treating many of your patients with lumbar extension therapy, especially this McKenzie exercise, now if you have not been able to identify your patient very well, if you use that in this type of group of patients, they are going to have more problems. So please, let's pay attention. They are going to have more problems. Okay? At the same way, these patients, they have negative SLR because it's not about the discs. If you ask them to lift their leg, they will lift it up and there will be no any compression on the nerve roots because their problem is narrowing of canal, not compression of the sciatic nerve. Even their slump test is always negative. You should look at that. So they said for the spinal stenosis patient, they have wide-based gait. You see that they like to walk with their limbs opened because when they do that, it pushes them into flexion. So they like to walk like that and that releases their pain. So that is the reason why there are patients that you will never ever tell them that try to straighten up when you are walking. The more you straighten them up, the more problem you give them. So they won't be able to walk for long distance and they will always walk with pain. So it's not every patient you put them to go into upright position, okay? So there are patients that when they flex a bit forward, you have to allow them flex a bit for them to walk longer, for them to walk faster, for them to walk better. So you should know that that posture they do, it usually reduces their symptom. So we should be able to understand all that. In imaging, we see that usually the MRI, in their MRI, the spinal canal is usually less than 10 centimeters. We say it's usually of about 18 to 20 millimeter. So J is millimeter square. So but what we're saying is in this patient, they are less than 10. Okay, so they don't even have as half of their canal is reduced. You see that narrowing very, very clearly. I'm going to show us some of the things what we'll do them now. Now, if you put them on the Bruce protocol is a treadmill test. The moment they begin to walk, before they will walk for 2 or 3 minutes, they will tell you their pain have started, especially when you put them to walk upright in extended position or in normal walking position. After 2-3 minutes, they can't reach 3 minutes because Bruce protocol is for 3 minutes. They will not be able to get there. But if you allow them to walk with their back down, so they will have, with the stool position, they could do that beyond that time. So you should know that these are patients with spinal stenosis. And of course, for them, when you give them cycling test, they can ride it for 1 hour because they're in down, what do you call it? The flexion position. So you can see that there are exercises when you give some type of people, they'll just be doing it and enjoying it. So you should be able to know that these type of people are those with spinal stenosis, not disc problem. So here is a table that I've been able to show how you differentiate so that we should be able to capture this as much as possible. I said in age group, it's a disc pathology. It's usually among young people, 20 to 50 years. If it's a spinal stenosis, it's in the elderly, usually above 50, 60 years. For pain pattern, usually disc pathology come with radicular pain, but it's usually unilateral. And that pain worsens with flexion. For these spinal stenosis, there is neurogenic claudication. Their problem is usually heaviness of limb, pins and needles, paresthesia that worsen with extension. Relieving factors, disc pathologies, when they lie down flat or they lie in extension, they have more relief. But for this one is when they lie in flexion or they sit down, they have more relief. The neurological signs in disc pathology is usually dermatomal. It follows the dermatome where the problem is, then the muscle where there is deficit. But in spinal stenosis, this can be variable. So it depends on where the affectation is more. For provocative test, SLR is usually positive for disc pathology. Slump test is positive, but here is when you do the bicycle test, and then it's only when you do the Bruce protocol, that is treadmill test, and extended position, that it will be positive. Bicycle test is usually negative. The imaging, this problem can be seen, and then you can see a nerve compression, but here it is a canal narrowing, and then you can also see some degenerative changes, usually on the vertebra or connecting tissues. These are some of the things you will see that differs. So let's look at this image. I want you to look at this image. Is there a disc problem in this image, especially where you see my red light? Is there a disc pathology?
No.
There is.
Yes, there is. Two.
There is.
There is.
Yes, there is. S1, L5, there is problem there. Then L5, L4 junction, there is also problem there.
L4, L5, L5, X1.
Yes.
So what type of disc pathology is that?
It is the bulging, disc protrusions.
Disc protrusion. I can see where the disc protruding to where.
Prolapse.
Prolapse. So where if it prolapses, you see it dropping now. Where did it drop out from?
No, there's no prolapse, it's protruding.
Now the issue here is that you guys have still not paid attention to the spinal canal issue. Now, if you look at between L3, L4, L5, and L5, S1, in fact, you look at L3, L4, you can see that there is what? Narrowing of the spinal canal.
The one over.
That's true.
Do you all see it? There's narrowing of the spinal canal, and your disc is not even going towards where those discs, the nerve issues are. You see that even if you are thinking there's degeneration in that disc, but it has not gone to where we call it a disc pathology. So you can see more of the narrowing of the spinal canal than more of the disc issue. Okay, let me show you one image where I have captured the names. You see that? Can you show me any disc problem at between L2, L3? Any disc problem?
Yes, sir.
There is extrusion
Where's the extrusion?
at L3.
L2, L3 junction.
L2, L3, there is extrusion.
Extruding.
What will you use to compare that there's an extrusion there? You have to compare L1, L2, then L2, L3.
Yes.
So is the size between L1, L2 different from the size of the discs between L2, L3?
Yes, significantly. No, the
Yes,
size
it
between
is.
L1, L2 and the size between L2, L3 is the same. There's no difference. The only difference is there's a slight bulging between L2, L3.
There's a slight bulging. But what about the significant spinal canal narrowing? Don't forget, I've shown you that this all whitish line. Look at your spinal canal here. This side. The spinal canal. Now look at how narrow it is here. See how narrow it is here. See how narrow it is here.
Yes.
So you can see that the narrowing is more obvious than any disc pathology here.
Yes.
So this is how you should be able to identify.
Who is this?
Who is that? Okay, maybe he's talking somewhere. So we'll see that.
Please unmute.
If you are not speaking to us, kindly unmute yourself. Mute yourself. Yes. So what I'm trying to say here is, if we pay attention more on this spinal canal, you will see that at L2, L3, the spinal canal narrowing is almost about 90% of what this canal has. Do you see it? It is the narrowing here.
Yes, at L2, L3.
L3, you can see. So it is more obvious than any pathology in this disc.
Yes. Is it coming from the spinal
process? The point you are
process?
talking about, that there is a type of protrusion or bulging of the disc here, around here. But it is not as obvious as the narrowing of the canal. So, likewise, the canal here, you have about 60 or 50% narrowing here, with another 80% narrowing at L4, L5 in this region. So the narrowing is more obvious, then you're likely going to give this patient a spinal stenosis and giving the patient a disc pathology, isn't it?
Yes.
So what you need to do next is, you don't treat this imaging. I've always advocated for us to understand that, please don't treat the MRI, treat the patient. So what are we supposed to go back and do here? We identify this. What are we supposed to do?
We need to screen the
we
spinal
go back
process.
to our clinical assessment.
Okay.
To see, will this patient have more positive assessment for this, or is likely to have more positive assessment for stenosis? We have highlighted these differences just now. Isn't it?
Yes, it is.
So please, you don't just look at the MRI and begin to confirm that this is what your patient has. No, you will first of all do your what? Do your clinical assessment, and your patient shows you he has more of all this spinal stenosis. What you come here to do is that this is just confirming it to you. Okay? Don't forget that you are likely to come across patients who have both pathology and what? Spinal stenosis together. You know, the human being is a complex system. What I'm trying to teach you is a modular system, identifying this pathology separately, identifying spinal stenosis separately. But you're likely going to come to some patient that has all these things put together. Are we together?
Yes.
So when you identify such type of patient, you come in and see what tests, you know, show more positivity between the disc pathology and the spinal stenosis. And this is where the holistic approach needs to come in. What do we start with? What are the major problems of the patient? What are the things the patient is having more issues with than what? So if the disc spine are the major thing he has more problem with, it means let's attend to the disc first.
What do you want to do? Talk to me.
All right? Ladies and gentlemen, are we happy with this? It's 11:30. I said I was going to give you some break, so please let's just finish some 2 slides, then we can go back to have a break and come back. So please, this is some of the things I need us to go back home today with it. Knowing that most of your patients, some of them are just basic disc pathology, We should be able to know what are the clinical signs of disc pathology, what are the physical signs of disc pathology, and what are the MRI or imaging disc pathology. So, and what are the management for disc pathology? When it comes to exercise for disc pathology, more of the McKenzie extension exercise are going to work best for you than doing any flexion exercise. So when you now find that your patient have more of spinal stenosis, that is narrowing of the spinal canal, so we must pay more on the Williams flexion exercises. And that is why you must know what you are doing. That makes you a professional. Most patients will think, what is this physiotherapy? It's not about just lifting your leg and lifting your hand. No, it is not that. You guys must understand. You can imagine how much you have paid to get to this point. And I know how much I had paid during the training to get to this point. So it's no joke when you begin to charge your patient 30,000 per session, 20,000 per session. This is the essence of the knowledge. You're not just using your head to treat. I'm very sure after this session, most of you will be more confident to learn how to treat your patient than what you were before today. And that's why I keep advocating that we should not come for this CPD just because we want licensure. We should come for CPD because we want to enhance our knowledge. We want to use it in a better way to help ourselves and help our patients. All right. So I just want to talk about a few things. Red flags. When you see your patient, either the spinal stenosis or the disc pathology, please watch out for red flags. When you see red flags, refer. A patient you see with progressive neurologic deficits, please refer. Patient with counter equinal symptoms, because patient can no longer hold urine. The patient can no longer hold feces, please refer. Patient with unwanted or unexplained weight loss or fever, that is talking about patient with likelihood of either TB or a type of infection pot disease, please refer your patient, okay? Because if you don't refer your patient, you're not going to be the one treating the infection. So just refer the patient. When they get well, you come back with them. Patient of any history of cancer or trauma, a fractured way, you're trying to assess your patient, you identify there's a fracture, a wedge fracture of a vertebra, refer the patient. You don't manipulate a fractured spine, okay? So that makes you a real professional. There's nothing to worry about. So please, we must know that when we want to manage most of these our patients, if it has to do with disc problem, let's try to do more of what? Extension exercises. These are the things that help our patient. And like I said, we should learn most of these McKenzie extension exercises. They are very easy. They are very, it's self management program. You can teach it to your patient. They will learn how to do it. Of course, you have what you call the NeuroGlides. The NeuroGlide are things I want to demonstrate, but I don't know if I'm going to do that during the exercise class. We're going to do that. Most of them, the core training, I'm going to show you some of the core stabilization exercises. We're going to demonstrate that during our exercise aspect. Of course, we say we must understand the role of physiotherapist in managing this patient, that your role is not just to treat and treat. No, the first role you need to play is your ability to identify the pattern and type of the problem this patient is presenting with, okay? Then you should be able to screen for any red flag. It's your job to screen for red flags as a physiotherapist. Then you should be the one that is going to guide the patient on evidence-based intervention. What are the evidence that this is what we should do? And then you should know as a physiotherapist, you are the one involved in coordinating the multidisciplinary team. As long as it's a non-specific back pain, then you are the coordinator. I need you to go now see a dietitian, wants you to reduce your weight. I need you to go see the psychiatrist because your pain is becoming consistent and persistent. Nothing seems to be working. I need you to do this. So these are things I want us to do. It's all your job as a physiotherapist. So let me ask these few questions. I said a 50-year-old person with unilateral leg pain and positive SLR. What do you think is the diagnosis? Disc problem or spinal stenosis?
Disc pathology.
Disc pathology.
Thank you very much. I'm happy with everybody. What should we treat the patient with? What is our management plan?
Extension exercise.
Extension exercises.
Exercise. And what?
Neurogliding.
Neuroglide. And what?
Core stabilization.
Thank you so much. So I'm happy everybody has understood this. So in summary, I said accurate differentiation is very, very essential as professionals. We should use clinical pattern to recognize, is it a disc problem or what do you call it, spinal stenosis. We should do this imaging only when it is indicated. And I say it is only indicated when you have identified a red flag. Then we should function, our treatment should be functional based. That is, we should focus on function to enhance, to improve the outcome. That is, whatever we do, let it be functional. All right? So, ladies and gentlemen, we'll go for a break. And I don't know, is 10 minutes or 15 minutes enough? We'll come back for our exercises. We're going to be starting with exercise therapy.
Please, sir, can I quickly ask a question, sir?
Yes, go ahead.
Come out again. Remove.
All right, sir. I know it's not really directly related to this, but I just want to ask. So there's a patient I just managed some couple of weeks ago. I suspected a red flag. I sent the patient for an investigation from the GP. So they confirmed that the patient is having wedge fracture. So now my question is, do you think later, after their own intervention, they send the patient back for physiotherapy? Do you think exercise or anything could actually help with a wedge fracture? So I'm thinking of referring back. So I need your opinion, sir.
Yes, you identified there was a wedge fracture.
Yes, sir. I sent for MRI, X-ray. I sent back for the GP. They did X-ray. They saw that the patient is having a wedge fracture at L1.
Yes.
So later, they send the patient back again for physiotherapy. So now, I don't know what they want us to do. I don't know. So
what did they write to you? Allaying your fear, because you identified that this patient has a wedge fracture. What is expected that the surgeon or whoever is seeing the patient is to write back to you that we thank you so much for quickly identifying this patient, and we have confirmed the patient has a wedge fracture, and we have taken 1, 2, 3 steps, and the patient is now fit for exercise or for physical therapy. Okay? That is in an ideal situation. Now, in a situation like ours in Nigeria, that perhaps the patient, the doctor may not even care. He just saw the patient, okay, we have written for you, go and take this drug and go back to the physiotherapist. Because sometimes most of them send this patient to you when they don't know what to do next to the patient. You must understand this.
I think that's the reason. I think.
Okay, so you in trying to help the patient is now thinking, what should I do for you? If you still recognize that this patient has a wedge fracture, all you need to do is get a maneuver jacket, okay? If you cannot get a maneuver jacket, get a very good back support and put to the patient and give the patient maybe vitamin C, D, or give them calcium to stay back at home and just move their limbs while lying down for another 6 weeks or 8 weeks and come back to see you. By then, you are hoping that the fracture will have done what? Consolidated.
Okay, thank you.
Point. So you just have to play safe, okay? So if you know
sir.
that the patient is having this and the patient is sent you to come back without any note, of course you lose your sense of professionalism. Okay, this is your back, start jumping. Why should you jump? Okay. So yeah, somebody is raising his hands up. Umar Bello. Umar Bello, go ahead.
Hello, sir. Thank you. I enjoyed the presentation. What I want to ask about all these patients with lumbar stenosis and disc problem? Is it at the court or anything? That's why you manage them?
I don't know, it's like there's a noise coming from behind you, so I'm not getting you properly. If somebody have understood him, can you please share his thoughts with me? What's his question? Umar, I said I didn't get your question. You have a background noise. So if you can restate the question, please. Otherwise, Nelson Ole, please go ahead.
Okay, thank you very much, Prof, for this wonderful presentation. My a little question, Prof. You know, when you were talking, you told us that people that have lumbar stenosis, they already adopt a posture that makes them to feel less pain by stooping. And now, when they come for treatment, we try to see sometimes we do extension exercises because we feel that the postural correction should be part of the treatment that should be given. But from what you have said so far now, meaning that once a patient has taken up the awkward forward stooping position that gives him or her less pain, that we shouldn't bother ourselves with the postural correction. Then, if that is what you're saying, sir, how do we now achieve reduction of pain and proper alignment of the patient during management? That is my concern. Because, you know, the mindset we have over this time is correct a patient posture, because anatomically that is what you are expected to have for a particular patient. And now the ailment has made the patient not to take up that right posture. What are we expected to do? Do we manage the patient constantly, you know, in that stooping forward posture?
Thank you so much, Nelson. What we're saying here is, you see, there is no ideal posture for any two persons. What you want to achieve is to put the patient into his neutral position. The patient stooping forward gives the patient a bit of relief. So your ability to open up the spinal canal will automatically bring the patient into more upright position. Okay? What we're saying here is you don't force the patient to become in upright position when you have not taken care of the spinal canal issue. It's rather you should do more of his flexion exercise to open up the canal, okay, than asking the patient to just correct the posture by going into extension. So this is what we're trying to say we should avoid, not forcing the patient to go into extension. No, our goal is to open up the narrowing of that canal, you know, but using the flexion position where the patient symptoms are less. All right? So, but saying the postural correction has to be the patient moving back into extension is not the good pattern. And that's going to cause more problem for the patient, because spinal stenosis, don't forget, is in the elderly. And you're just telling an elderly person to say, no, you must not stoop. Well, I think that is not a good treatment approach. For an elderly, it's okay for them to have to stoop a bit in forward, and then our ability to now work on them in that position until they have little or no concern is what should be the goal for the treatment. Not that postural correction to come back to extension is what we should be bothered about. This is what I'm saying.
Okay, yes. Thank you so much, Prof.
Somebody is asking in the question here, he said, what about situations where a young person presents with back pain and can perform lumbar flexion that relieves the pain? Under what category should such patient belong? Well, like I mentioned, there are a lot of interplay between disc pathology as well as spinal stenosis. So if the patient can do some lumbar issues, we should also demonstrate most of these tests we're talking about until we're able to be sure that the patient is having more of spinal stenosis, not a disc, because 1 or 2 tests cannot give you the accurate thing. So you have to do most of these tests over and over. Don't forget, according to McKenzie, it will tell you repeated flexion. So you have to do it over and over and see if that generates their symptoms or not. So Rahmatullah, this is one way of identifying this. So just one movement cannot give you the answer. You need to look into what we have mentioned and do some other tests and see how the patient will respond. Yes, but this is a situation that is not common among the young persons. That's what we're saying, that the disc pathology is more common than the spinal stenosis. Another person said, I'm not clear with the previous case scenario where other colleagues said the patient would benefit from extension. Okay, the question we asked, that the 50-year-old person who we said, what did I mention? I think I was talking about 50-year-old with lateral pain and positive SLR, but we all agreed this was clear. I'm sure the person asking the question maybe was not following us very well. That was why he missed out that part. I will say, please try to look into the slides again. You will be able to catch up. Yes. Sir, what's the reason for pain, inflection, or extension in each of the pathology and not the other? If I get this question well, he's saying, why is it that for the pain, for somebody with disc pathology, and he goes to flexion, and then he has pain? Why did he have that pain? I'm sure that's what he's saying. And for the person with spinal stenosis who goes into extension and has pain, why did he have pain? Why is it that the other person with that pathology did not have pain? Well, it's still the same reason, because you have not been following. If you pay attention, most of these things were mentioned. I said the person with disc pathology, bending of our back, flexion is one of the commonest things we always do. That's what McKenzie said. McKenzie said 90% of our day-to-day activity is in flexion position. And when you flex your back, your intervertebral discs move into the opposite position. So when I'm flexing forward, my disc is going opposite, that is backward. And behind there is where I have my nerve roots. So if the disc goes there, it irritates that. So a person with disc pathology, the moment it goes into flexion, the disc will move and he's going to have pain. This is the simple thing. But the other guy with spinal stenosis is that it is narrowing. So the moment he wants to go to extension, you will see that the narrowing will also become more narrowed. So there will be more pain. So this is the reason. So let's please pay attention. Our break is now remaining only 12 minutes. So I will please want us to go and do the break and come back. What if the patient has no any radiation of pain, negative SLR, and 34 years? Yes. Did you know? Somebody said, what if the patient has no unilateral radiation pain? Negative SLR and 34. Extension increases pain while flexion reduces pain. But you have not given us what pain does he have? What is his own major concern? You're only telling us he doesn't have radicular pain. There's no radicular pain, and he's a young person, but extension increases the pain. When he does extension, it increases pain, and flexion reduces the pain. Are we saying this is still spinal stenosis? I'm sure that's the question. Please, I told you there are a lot of other activities you will need to do to establish. Okay, so let's do our assessment, and that's why we had to do assessment last week before we jump into management. I'm going to do management today, and that's why I said let's get clear these things before we know which management do we do to who. So this is the reason. I thank you guys very much for paying attention. So we're going to have a break for 10 minutes, and by 12 noon, immediately, we'll continue. Thank you very much.
Thank you very much, Prof. Thank you, sir.
eléyìí náà jẹ́ nǹkan tí a fẹ́ dì mọ́.
It hasn't started. It's 12, no? Like, you want to type another one? You want to retype it? I don't know why it's moving it. When you move it, they have cleaned it. Right. Right. If I go see like this, then take it to uppercase. Delete it. There has to be space now. I stand alone. I should stand alone, then space. The space bar.
Come back. Okay, can we start? Are we back?
Yes.
All right. So we'll be going to the aspect of using exercise therapy, the management of low back pain. So we start by identifying what are the objectives of exercise therapy. Why do you need exercise therapy in managing low back pain? If you remember vividly, I mentioned that the current guideline approved and advocated for the use of exercise therapy. There are recommendations and there are evidence that exercise is one of the major things that we should use for managing low back pain. But what type of exercise should we do? Which exercise? How should we do it? So this is what we'll be looking at today. Now, the goal is, number one, we want to use exercise to elevate pain and disability, because that's what your patient is coming with. If you remember our last class, the first impact on physical ability, LSP, low back pain, on what we say, the impairment that it caused on the physical ability of an individual is pain and disability. So we want to use exercise to alleviate pain, to take away the pain and improve the disability. Number two, we use exercise therapy to improve strength and coordination. That's what we call the spinal control. And then number three, we use exercise therapy to enhance mobility and endurance. That is, ability of this individual to hold what they are used to doing. We also use it to boost confidence and then to reduce fear. That's fear avoidance. When you have this, when you do exercise, you try to take away fear avoidance of either walk or fear avoidance of physical ability. You see that you have more confidence to do more things. And then your exercise is there to prevent recurrence. In one of our classes, we mentioned that the major problem with low back pain is there is high recurrence level. And we mentioned that studies have shown that the first episode of low back pain is likely, we call it spontaneous recovery. Whether you treat the patient, you don't treat the patient, he's going to recover. So don't start celebrating because you saw a patient yesterday and today he said, I'm okay. That's a spontaneous recovery. So our aim when you are seeing such type of patient is how do you prevent recurrence? And exercise is one of the ways we use to prevent recurrence. What's our theoretical rationale? What are the rationale behind the exercise? Number one, our exercises are based on biopsychosocial model. The thing is, exercise is used in such a way that it does not only addresses the pathology, that's the biological aspect. It's not just only the biology. When you exercise, you already know that exercise improves what? Mental health. So exercise is not only working on that pathology, say there is a weakness, it's just going to work on the weakness. No, it's also going to boost your what? Mental health, quality of life, confidence, and so on and so forth. So it helps us. So we use the biopsychosocial model to design our exercise. Number two, we use exercise to recondition both the muscular and neural system. Deconditioning is what they used to do in those days. You go to a hospital with low back pain, they chain you to the bed with skin traction. That you should not move. If you move, your pain will start. You see, the doctor is the one that created the trouble for you, sir. So we use exercise to begin to tell the patient, now, okay, just start moving your ankle. Now move the knee. Now move the hip. Now lift the leg. You know, graded activity, gradual institution. You begin to come in gradually as we move. And of course, we're also going to use exercise to reduce mechanical stress and central sensitization. You know that when you have pain, there are a lot of aspects in the body that are being sensitized to the pain. So what exercise can help you to know, how do you reduce sensitization? Don't forget, even when the patient tells you I have pain, it's possible that even the disc pathology, the disc problem is there, but you can desensitize the disc. That's the essence of all these, your laser, ultrasound, the shortwave data. You are using it to desensitize that disc. Do you understand? So we use it for desensitization. And of course, you use exercise to enhance the patient autonomy. because we'll begin to tell the patient, do it yourself. Lift your leg 10 times in a day, do it 3 times in the morning, and things like that. You are using it to create autonomy. The patient begin to feel, look, now my body is my own. It's not for the doctor. You know, the doctor will come into the ward and see his back patient. Hey, who asked you to move? You spoil the back again. Because why? He thought that the movement will create the problem. Okay, so let's look at the different types of exercises we should be doing. Now we talk about core stabilization exercises. The core stabilization exercises are exercises we do to ensure that those internal muscles that stabilizes the back for other muscles to move. Don't forget, when you say core, you're talking about the internal back muscles and abdominal muscles that grab the spine. They grab the spine, you know, they're not the movers. They are not the movers, especially the multifidus muscle, the rectus abdominis, the transverse abdominis. These are all not movers. They are stabilizers. What they do is they grab the spine for the movers to move. You know, you have the quadratus lumborum, the long muscles of the spine, erector spinae. All these are the movers. They are not the stabilizers. What the stabilizers do is they grab onto the spine for these guys to be able to move your back and forth. They are like pillars. Okay? So let's demonstrate some of these core stabilizers. We try to say core stabilizers. There are different core stabilization exercises. One of the most prominent core stabilization exercises is what we call the McGill core stabilization exercise. The McGill core stabilization exercise can start even, no, sit down, by sitting down. At early stage when the patient is finding it difficult to move any part of the body. We call it the abdominal raising or hollowing. What you want to do is you want to hold in the abdomen and the glutes. It's not that you want to be doing, no. I will not want you to hold the respiratory muscles. Because when you do that, it means the diaphragm you are working on. You're not working on the core. The core muscle is, I want to tuck in the navel, and then I think I want to pass out gas. I'm trying to hold it. That's what we call the abdominal brace. And then you release. You release. So, but for the 4 core stabilization exercises, we start them in lying position. It's like the first core stabilization exercise is called coil up. Okay? So we start with coil up. Please, okay, you be on 4-point gauge. Just kneel down. Okay?
Now we cannot see
This
clearly.
is what we want you to learn how to do. The moment your patient is able to be in this position, you can easily ask the patient, pull your tummy in, okay? Then bring it out, you relax it. This will go this way. What's the head? Then go down. You see that? Then you go in. According to McGill, this exercise could be repeated like 10 times. At the moment you begin to do this, especially if it's a disc pathology, they are beginning to work on the disc material. So it makes it soften, and then the disc will also begin to know that it wants to work. Of course, you can see it is less painful, but you are not dragging the patient in any way. So this is a very good exercise for the back. We go like that. No, so this is the first one. The second core stabilization is going to lie on the back, and then we do the coil up. You know, before now, you have what they say sit up. And sit up, you're going to be sitting up, sit up, let's say, since you don't have pain. The moment you do this and you sit up, already you are working on where there is tension on the spine. Because when you lie down and sit from this lying position and you sit up, already you are putting pressure on the disc. especially on those values. So if there is any vulnerable time, they are going to slide it off. Because even a patient who has gone through any of these things, you don't ask a patient with back pain to sit up from lying position. We teach them how to sit up. What do? We ask you to lie on your side. You know, when the patient is lying down, you don't do other people. Now roll on this, put pressure on this hand, and push up. So that there will be no pressure on the spine. Okay? So coil up, what it does is while we're trying to work on the abdominal and back muscles, we're going to support those lumbar regions still on the back. Will not come up. Do you understand? So the first thing you do, you ask the patient to stretch their hand. Stretch your hand up, just relax your neck, keep your neck relaxed. Now you ask the patient, pull up, come up, stay like that. Pull up, 30 to 45 degrees. Come on. You can see that all this part of this back is not moving. Do you understand? So at this point, it stops here. So at the beginning, you just allow the patient to come up as best as they can. You don't say, no, pull up, no. So at the point they can still pull up, you don't allow the lower back to get out of that.
I can't see it though.
The video is gone, sir.
Then if I need to progress,
The video is.
the moment you are doing that, when I say come up, you'll see that there's real tension in those transversus abdominis, rectus, and all that. Okay? So you're working on them. The moment the patient can do this, I will now put it more difficult by reducing the carrying angle. And put the patient to hold the hand behind the neck this way. Okay?
That we are not seeing.
Pull up yourself. Is it not more difficult? It's more difficult. So you see that that's a progression. And the moment we're finishing with this, we begin to move to the next stage. The next stage, you release this.
We are not seeing, sir.
Bird dog. We started with the cat dog initially. So this is the bird dog. In the bird dog, what you do is you ask the patient to flex both knees, and then we begin by lifting one of the knees. Both knees and the extended knee are all going to be in the same position. Then you lift the hip up. Lift up your hip, tuck in the tummy, and count. You ask the patient to be counting so that they should not be using the respiratory muscle.
Zoom, I cannot see you.
You cannot see
the
People on Zoom, people on virtual this they cannot see.
Can you guys see what we are demonstrating online?
We can't. We can't.
No, we can't see anything.
We can't.
You cannot see it?
Yes. People on virtual
For 5 minutes now.
Yes, we have been calling your attention.
Sorry, let's see if we can go back. Logistic officer, are you using my system or your system to show? So what is happening that they cannot see? It's your own network. Unfortunately, we are on different networks. So please just bear with us. Let the logistics officer fix it.
Go home now.
So it means some of the things we have demonstrated before was not seen.
Yes.
Okay. So is it there now? So can you guys see it now?
Yes, it's back, sir.
It's back.
Yes.
Okay. So I think I stopped where I was discussing coil up, right?
Yes.
Yes, sir.
Okay, so let's look at the coil up. What you need to do is to ask the patient or your client to stretch their hands up and then pull themselves out of bed. At the initial stage, they don't pull to the best they can. Don't ever allow them to move into sit-up position because already there's a tension in the spine. So when you are doing your coil-up, you are sure that you are keeping the back, and the back has to be positioned, supported with the couch. So the back will not come out. It's only the abdominal region you are working on. So when you touch it, you are going to find the contraction at the abdominal region where you scare both the transverse abdominis, the multifidus muscle that crosses through there, and other muscles all contracted. So that is one about the coil-up. If I want to progress on the coil-up, I will ask the patient to reduce the carrying angle, and it goes this way. You see? Ask the patient to do this. This is more difficult for the patient. So it's a progression of what we're doing. So I think this is where we stopped before now. So the next thing we're trying to do in our core stabilization exercise is what we call the bed dog. In the bed dog, we ask the patient to flex the knee to 90 degrees. Then one of the limb is extended to 180 or 0 degrees, but it's left at the height of the knee. Both knees will be in the same position, and then the hip will be lifted up. You ask the patient to stop in their tummy, and then they will count. The essence of the counting is to make sure they are not holding the respiratory muscle. So you count, let me hear you. 1, good. 2, good. 3, good. 4, good. 5, good. 6. Then you change. According to McGill, you should not allow the patient to go to 7 seconds. They count until 7. They say after 7 seconds, fatigue will set in. And when fatigue sets in for a patient with back pain, then pain will begin to develop at that muscle. Now, the essence of the strengthening will be lost again because pain has gone. So please, let's be careful with that. So we repeat on the other side. You are expected to do this as much as possible as the patient is responding. So for me, I like to start with 3 repetitions. As we're increasing, we go to 5, we go to 6, 8, 10, and like that. So this is another one. So I will work on both the abdominal and back muscles. We're supposed to work on the quadratus lumborum. And that's why McGill now talk about the side dog. So for this, the patient is going to lie on their side. Then you put one of the hands at the kimbo. Okay? Then you try to lift your hand. You put it on this, put it on the couch, put it on the couch. No. Just put your hand, feel free, here one. Put this hand at 90 degrees, like that. Good. So this angle at the initial stage is going to be at 0 degrees or 180 degrees. That's the angle on a straight line. So you ask the patient to lift the hip in this way, and then they can start by holding. You count 6, it goes down. So the next one, you count another 6, it goes down. The next thing is the patient is going to now bend these both knees to 90 degrees. When they bend to 90 degrees, we'll introduce some range of motion in the movement. You lift up and then move back and forth. 1, 2. Don't move your hips. Now, what is wrong with this one? You know, so we do this. We go like 6. Yeah. So after 6, we can ask him all the time. Okay, I hope they can see us live. See they have live?
Yes, sir.
You can see.
Now we can still have another variant of this when the patient is getting perfect the movement. And we're going to extend this by lifting up, and then we lift this limb. You can see you have increased the tension. And at this one, you will now move by 1, like that. So you can see you need to be well stabilized to do this. Don't forget, last week we talked about the Sorensen test, which is a stability test. If you have this instability, then you won't be able to do all this. We'll have to train you for all this activity. So the same thing you have done here, you turn to the other side to do it. So the last test we do among the core stabilization is what we call the planking. Okay, you turn on your stomach. Please kneel down. Kneel down. Good. Before you do this, like this 4-point kneeling, you know, what you are dealing with your hand is the point. How to tell your 4-point kneeling or 2-point kneeling? Okay. So in this case, we're looking at the patient has built most of the muscle. So we're trying to do balancing and coordination. So you put, let me have your right hand stretched, right hand. Good. And then left leg. Straight, 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 straight. Yeah, like that. So you start by this. You're just trying to stabilize the patient. You can see when you don't have balance, you'll be able to do this. Okay? Now, if this patient is able to do this for some time, we will now start by dynamic balance, where when the hand goes to the right, the left will go to the other side. Okay?
The next one is
Come forward a bit.
It is no longer showing.
It's a progression. It's a progression. That's how we started from the lowest one to the highest one.
can't see it too.
Can we all see it from there?
Bro, the video is stopped.
The video is stopped. Okay. Our videographer is coming up. He needs water. Hold on, let him finish. Okay, are we there?
Yes.
Yes. So this is an advanced state of the stabilization exercises. While you're having this, the patient can now walk, so we move in an alternate pattern. So you go 1, let's move, 2, let's go, 3, we'll go, 4, almost 5, last one 6. So we change. In this case, you realize that patients who are right dominant, they can do it on one side better than the other side. And then some people, if they have a unilateral affectation, which is more affected, they will not able to do it more than on the other side. So it's something you can use to assess that the affectation is more on one side than the other side. But at the same time, you must understand there's laterality. There are people who are stronger on one side. Like some people can be strong on the right side, but weak on their right leg. Some will be weak on the right left leg, but strong on the. So you must understand that so that you don't misdiagnose the patient. So for the last thing, the patient goes into lie flat on your stomach. So planking is a resting stage. It just adds to the confidence of the patient. Go this way, like this. Okay, let's go. You want to pin in your limbs, then you plank. Let's go. Pull up like that. Then go. We have flat tummy. Then you look up. The patient is able to stabilize the whole limb. So when they do this, they feel happy themselves. So when we do this, we make it more dynamic by coming through this 1, 2, 3. You see that? So when you come up this, all your patient get the full stabilization. They have to
tell them, Michelle, to flash that moment desire again.
you got to lie down. So this is called stabilization exercise.
I don't have to call her number again.
Always think of something that you can put it in your phone or based on patient preference or based on patient's pathology. So this is a common thing that you can always do, and then you have your evidence of doing it. You understand? Now we're also coming to aerobic exercises. In aerobic exercises, you want to be sure what your patient can really do and what they cannot do. In my day-to-day clinic, when I come for my aerobics exercises, they are much more integrated into all that. If I'm treating my patient, I get the patient, whether it is spinal stenosis or disc pathology, I try to introduce aerobics. Because why? You need the patient to have both cardiorespiratory fitness in general and specific to the body. So what we're going to be doing is a general cardiorespiratory test. What we're supposed to learn is to start with some general warm-up. So for the moment, we just ask the patient where your knees, you know, just over it, not down on the floor. That is next. 1, 2. You know, if a warm-up, feeling the body that we want to move. By the time we go to 10, the patient gets that readiness you want to do. So the next thing is to bend the knee and lift and go 1, 2, 3, 4. I want us online people in our rooms so that we can participate as we are trying to demonstrate this. You can feel what your patient is likely to feel. Okay? By the time you 10 of these, you find that your patient is having more confidence that they can move. So we now go to this. The right leg only. 3. 1, 2, 3. Let's go. It's 10 times. 5, 6, 7, 8, 9, 10. Then we change to the left. 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Then we go with both legs. We go 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10. Good. You come back and back. Good. Now, when the patient do this, they see that, oh, this job is not easy. They begin to get happy with themselves and happy with you, that they are beginning to feel themselves. But for people with back pain, the one that will complete this session, they will be clapping for themselves. And this is a good news. Now, the main thing that all these preliminary are meant is to see how to pick up the hands and the body at the same time. So we do cycle in the air. This cycle in the air is not an easy task. It's more difficult than doing cycle in the animal, and I challenge any of us to try to do it for 5 minutes non-stop. Let's try. So, but for your patient, you will start with only 30 seconds. 30 seconds. So you open up your timer and give to the patient. Most of them, after 10 seconds, will collapse. That's when they will recognize that, oh, I need this. You know? So the timer you'll be using will not be the source of motivation. By the time you try it again, you see they get to 15 seconds. More than when they are 20, 30 seconds. So they tell them we want to do this until we get to 4 or 5 minutes. So that will be the time. So this is it. So this is all what we've been trying to get. But you will not come here just to the patient and start doing this. No, you prepare the patient's mind and the patient's body. It's body and mind that make it. Who is timing this guy? Okay. All right, relax. So this is the exercises that we use to build aerobics for the patient and cardiorespiratory. The moment you finish this, you're supposed to go into what they call the endurance, at the same time, flexibility and stretching. So you have to put all together, flexibility and stretching. So the first flexibility we want to do is to ask the patient to hold something in his leg, which is more of an endurance. Let's see, can you hold this for 30 seconds? 1, 2, you know, say I'm pulling up both the hip, it's what do you call them, the quads, and all. 5, 6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Change 1, 2, 3. All the abdominal muscles, everything is working. 5, 6, 7, 8, 9, 10. So with all this, the patient will shout. The guy is fit at least to this extent. But for most of the patient with don't speak over pain, they are going to see this as quite a challenge. Because this one is endurance. They are challenging how much can they hold on to an activity. At the moment we see them holding themselves back, they have more confidence. They are happier at home. Means I'm still strong enough. I'm still good enough. Okay? So from this endurance exercises,
Dynamics, you can use this endurance alternate or
exactly. Exactly, and that's what we're trying to integrate them all in one. All in one. I can get about 1 million of that. Sorry, our videographer is coming up. The video is still happening.
The video is gone.
Yes, it's coming up. The network from the side is poor. Are we there? So we've been able to see some of these exercises we do with endurance. So we want to go to the same where we want to do flexibility and stretching. Okay? So, and when we try to stretch, like I said, it's not every patient that needs stretching as often. You can stretch the patient maybe once or twice in a week if you have to see the patient. Like your patients with disc problem, when you lift their leg, you see them having pain 30 to 70 degrees. It's not a stretching issue. They don't have a stretching problem. They have a disc problem that is holding the sciatic nerve from opening up. So your concern is how to open up the sciatic nerve. You stretch patients that have shortening in their hamstrings. You stretch patients that have compression at the sciatic nerve underneath the gluteal muscle. That is performance syndrome. Do you understand? The performance model. So if I have to stretch my patient, what I do is I bend the knee into 90 degrees, and then I'll put this like in our favor test. You ask your patient to grab the knee, they will participate actively. So the moment you come in there to do this, a patient with tightness will tell you there is a pain in this side. They'll tell you there's a pain in the sciatic nerve. So if it's more of a piriformis muscle, the patient will allow you to push much more forward. If it's sciatic nerve, the resistance will push you back.
Yes, our video is not bad.
Do you understand? So that's why you must not force it as if the human
The video is bad. We can't see the video. The video is not bad.
What stretching are you doing? So the same way, you do the same thing on this side. Okay? So for patients with spinal stenosis, because I'm going to push them into flexion this way. The moment you do this, they will be saying, it's painful. But go ahead, doctor. They'll be telling you go ahead because as you're going further, they're enjoying it. Because it's pushing them more into flexion. You get it? So it's the same thing. Now, when we're here, we put both knees, especially patients with spinal stenosis, put them in this position, they'll be happy, and then you go to that. You see? They'll be happy. But you can't do this patient like this. You don't think I ever like, I don't care. I don't want to. So we need to understand when and which are we. Patients with this problem are happy if you put them in prone line. Go to prone line, and those are the patients we start our exercises with coil off. Put down your hands this way, and then I say lift up, come up. This coil off. No, this is back extension. and then they go. So many of your derangement syndrome, according to McKenzie, or this problem, the moment you start doing this, they will be happy. And they will tell you my symptom is going down. Do you understand? So, but patients with balance stenosis will tell you I like you are right. Sorry, the problem is increasing. So you must know when and how or what to use it. That's what makes you a professional. Okay? Now, for most of our patients, please lift up. Okay, anyway, let me keep this one. We're not going to talk about that when it comes to the manipulation, or we'll talk about the mobilization technique, because we need to mobilize the spine as well. This is a general movement and exercise we're talking about. You know, the aerobics, you know, endurance, flexibility. These are general things for the patient to be up. Most of us always think it's the manipulation that is the real bad issue. I am sure when we are growing up, when we see somebody doing manipulation in clinic, we think that is the real. Unfortunately, the current evidence has shown us that that is not what we should do. It should not be advocated. Acupuncture, all this, I don't know we should be advocated. We should use these things not as time alone, but we should use it when it's demanded, when it's required. Do you get my point? All right. So let's see, we want to talk about strengthening and motor control, all the McKenzie exercises, all these come together. Now for patients mostly with spinal stenosis, one of the commonest problems that will come with is muscle control or stability control. Don't forget the patient is already old. So by default, he has what? He has balance problem. We mentioned that one of the common signs in spinal stenosis is that they are elderly. Is it not? That they are elderly, and if they are elderly already, there is a balance problem. Already there is a coordination problem. So these guys cannot balance themselves properly. So one of the things they benefit during treatment is balancing technique. So, and this balancing can be either in sitting, in standing, and then even in walking. So you give them what we call perturbation. Please, sorry, come down. So we want to start with the Romberg text. That Baba, I just want you to, you know, stand the way you normally stand. And the old man tried to stand as much as possible, trying to feel he's standing upright. But no matter what upright he has, you see him like that. Okay? Now, how do you push the center of gravity this way? Has he not distorted his balance? And that's why somebody was asking me, do we now continue to encourage them to become imbalanced? By doing the flexion movement? No, we only need them to move in that way, but we have to correct all those inabilities. So one of the things you do when you want to do the Romberg, you start by holding the patient and ask him to close his eyes. Now this patient is closing the eyes with both legs on the ground. Then you ask the patient, take your right leg up. You see? Take it up. The moment he takes it up, you try to release one hand. As you are releasing, you know they will be struggling to get his balance. They're trying to use both the vestibulocochlear and the side to enhance his balance. So it means what you're doing to the patient is stimulating the brain to control his movement. Now, the more you keep doing this, the more you tell him, open your eyes, and you stand, then you give perturbation. Perturbation means that yes, you're trying to distort the balance. You might start with both legs, keep your leg, you know, I do this, not knowing, letting him know. But of course, somebody must be protected. You know, if I want to give perturbation, my hand will be like this. If he's going, I will have to grab back. You know, I do this. You give this. You want to see where does he respond to and where he cannot respond. Don't forget at that elderly age, it may not be suffering from only the back problem. Maybe arthritis is there, maybe brain injury is there, maybe some other functionality problems are there. So you take it holistically and see how these patients are likely to do. So as we do this, we begin to ask the patient, walk to me. When he's walking, you put obstacles and see, can he manipulate himself, crossing one obstacle before the other? And he goes zigzag and stabilize. So all these, they're trying to ensure balance and coordination for him. But for patients with disc pathology, usually their stability and balance problem are only related to the disc. If you correct the disc issue, it becomes very comfortable with his movement. That problem will be eliminated. Do you understand? And don't forget, we said they are mostly young elderly people, so young adults people. They are not the elderly type, so they can easily correct their issue. So we put them into strengthening. Strengthening can come in different ways. Of course, it depends on what muscle power you with. A patient with power 3, you want to build power 4, either you're using it's either you're using an external weight, or you're using the patient weight, or you're using an external support. Anything you could use to build more weight will be acceptable. So I said strengthening can come up in terms of building the muscle power from power 3 to power 4, power 4 to power 5, or building the muscle power of the abdominal muscles, back muscles. All these are things we could do. We can as well work on the motor control. Our basic problem we should know is if you want to give patients Mackenzie exercises, you must be sure that you have cleared the patient of any vestibular cerebral efficiency. That is, it does not have a VVI. Because you want to ask patient to go and come back, go and come back. It's a repeated movement. The moment he's doing that, you will find out that if the patient is not stable enough, he's going to have issues. Excuse me 1 minute. Professor.
Yes, our video is not showing, please. There is no display of video, please.
Okay, sorry, I lost connection briefly. Let me share the slide again. So we talked about the McKenzie directional preference. In the McKenzie directional preference, what we're trying to talk about is which treatment does the patient feels better with. And somebody was asking me if this is a disc pathology and the patient is now having relief with flexion. Okay. Will I still go back to flexion because I've termed it as a disc pathology, or what should I do? Now, it depends on what are the factors you have used to diagnose your patient. If that diagnosis that has to be accurate. If a patient is telling you most of his pain is relieved with flexion, and the patient is a young patient, you know, so she said extension gives the patient more pain. That she feels that patient is not likely to be a disc issue. Of course, we agree that only young people we see with disc problem. But it doesn't mean that you cannot find spinal stenosis among the young. You understand? So that's why it's very, very key that we have a very good diagnosis. According to McKenzie, whether you have classified it as stenosis or disc pathology, what he's saying is repeated movement that relieves the symptom should be what you practice. The unfortunate problem with that is this. You started today that this patient, you do flexion and they tell you is better. You do flexion is better. Tomorrow, let the patient come. You are doing flexion and high this pain attack. What do you do? What will you do? So it doesn't mean that that's what you do. So it doesn't give you a good sense of direction. Okay? So it means you still need to go back and ensure what is the point, what can be assessed. I identify what approach are you looking at. So because it can be confusing most often. What we say, your assessment is a continuum, it's a continuous process. You assess and reassess. You assess, reassess until you're able to establish that this is the situation. Because we have still repeated findings. You know, every time you assess, this finding is always repeating itself. So you'll be able to make your diagnosis and then your treatment can go up as such. So we should also know that during our exercises, we should do exercises that will return the patient to work. Don't forget, if you are looking at sports injury, your player is not yet well until he goes back to be able to play again in the pitch. So we call it return to sports. So we should do also return to work. Okay? So when we're doing our training, imagine that the patient tells you his office in the second floor of the establishment, and there is no lift, there is no escalator. So you know the Nigerian syndrome. You are working in the head of service or the federal secretariat here in Kano. I know that there's always no light in that place. MRTV's office used to be there. So if you go, just know that you are going to do endurance training. Okay? So now the patient wants this back pain. It means we need to start training the patient how to climb and come down. It has to be part of your treatment technique. Because until and unless the patient allows goes with office, come down without any problem, then the patient will not return back to work. So you should give functional tasks. If the person is a housewife and she needs to do her hot chores, you know, she needs to cook, she needs to wash, she needs to do this. You should be able to create tasks that are functional. Even if it's a student or whoever, you create functional tasks in those exercises and activities they will be doing. And of course, we should also add into what we call the yoga or Pilates. These are all training styles for stretching and ensuring your patient has flexibility to return back to work. There's also neuromobilization. I think there's a place we are going to discuss neuromobilization more. Okay, because under neuromobilization, you have what we call the neurotension, and then you have the neurosliders. We're going to see how all this works. There are also something we will demonstrate here. So, we talked about our core stabilization. We said this focuses on the deep trunk muscles, like the transversal abdominis multifidus. We have seen it. And we said like abdominal bracing, bird dog, and bridges. We have demonstrated this. Of course, the flexibility exercises like hamstring, all we have seen that, motor control, and then the other exercises. Now, let's look at exercise prescription. Please sit down. When we do exercise, this exercise is said to be what? Medicine. And medicine has to be what? Prescribed. So our exercises have to be prescribed. And in our prescription, we use the FIT principle. And in our FIT, we say it's the frequency. Our frequency, most of our clinic, why our patients don't respond is that we say we do therapy once in a week. In some clinics, they say once in 2 weeks. When will the patient ever get well? I've seen in a clinic, they say a stroke patient will come once in every 2 weeks. It's like 4 weeks. It's a workload. This kind of patient, so I know that you are not doing therapy. No program. All right. So if it's exercise, the patient has to do a minimum of 3 to 5 times per week. Okay? And the intensity we said is our repetitive maximum. The endurance we should do at least 11 to 13 times. That's the repetitive we want him to do. The exercise time should not at least between 20 to 60 minutes per session. That is the whole exercises you should do to at least be for 20 minutes to 1 hour. Your exercises you want to demonstrate, that is the drugs they will use should vary so that they should be enjoyable. You can see what we have done now. We added aerobics, we added stretching, we added strengthening, we did some balancing, coordination. So it should be like you're giving a drug for heart disease. You know, by the time you are giving a rosuvastatin, there's a rosuvastatin, you're giving the patient spirulina, dacton, you're giving the patient amlodipine, you're giving, you can see that the one patient will take like 8 drugs to take care of the heart. So it's the same thing, each of them doing a different action for the heart. We said the volume of the exercise should be the total number of sets, how many sets we should do, and then for how many repetitions and how many times. So all these must be designed. And that's why I like the UK clinic. The UK clinic, they have a soft copy or software of how your exercise is being designed. So all you need to do, just go and input and print and give the patient. These are your exercises, and this is how you're going to be doing them. So to aid self-management, okay? And then we talk about the progression. I say in general, progression has to be gradual, and then it should be based on response. How is your patient responding? Don't be too enthusiastic that you want to change what you are doing. No, is the patient responding to what we are? Like when I was demonstrating the coil up, you know, we started with stretching the hand. Don't just be thinking, okay, let's bend there. But I have not finished one. You have not finished level 2. How can you go to level 3? Eh? You have to at least finish the pre-clinical before you go to the clinical level. So you have to do it one at a time. I said in stages of progression, we have the acute stage, the subacute phase, and then the chronic phase. In the acute phase, our concern is we want to control your pain. We want pain to go down. Okay? So therefore, when we are doing exercise, it's mostly isometric exercise. Because we want pain to go down. We won't want to be doing any jumping that will be making pain to come up. So most time is you are lying down, a static quadricep exercise, a gluteal exercise. in that sitting position or a lying position. So our concern is we want your pain to go down. In the subacute exercise, our phase is about endurance and mobility. We want you now to be able to move and then to endure your movement. And then in the last phase, which is the chronic phase, your progression will be based on your strength, function, and then task. You know, the simulation of the task. Can you do this? Can you do that? That's what should be our aim. It gave us a table here where we can now see in the early stage, these are different exercises you should do, like the bracing, abdominal bracing, pelvic tilt, and I told you the dosage. You should do 10 repetitions 2 times, so 2 sides, okay? In the mid stage, that's some acute phase, you should do the bed dog exercise, you should do the bridging exercise. Of course, you should do 10 to 12 repetitions. According to McGill, that you count 6, but you should do 10 to 12 times. So it's something you should do as much as possible, all right? Then we do it twice. Then we go to the last stage where we do the planking and 1 sitting. You know, we did the planking, right? So all these are things we should learn how to prescribe. Again, there are some special considerations. While doing exercise, you should be able to educate your patient on neuro pain science. That is how to understand pain. You know, when a patient feels there is always fear avoidance of physical activity. He's thinking, I don't want to go and do this thing and my pain will start. You need to address the patient. The first thing you tell the patient in low back pain does not mean harm. You have to cancel that in their brain. So when they understand, you see, the more pain you feel, you think the more your back is hurting. It's not like that. This pain is as a result of inflammation. Do you know one of the things that causes inflammation? The type of food we eat. Because most of us don't know that. Inflammation is precipitated with the type of food we eat. If you eat more of these junks, like Mr. Beach, what do you call them? Chicken Republic, all those things, they are inflammatory enhancers. They make you have reaction that gives more inflammation to the tummy. So these can give you problems. So we adjust exercising. And of course, when patients do exercise and you see that their pain increases, you need to adjust the exercise, reduce the number of sets, reduce the amount of intensity. You adjust, okay, so that the flare-up will go down. And of course, we also look at when they exercise, they are more pain, you still assess your patient for red flags. Maybe there's something, there's another red flag, you see it. And of course, we should use outcome to monitor progress. What are those outcomes? Pain intensity. If after all these things I've done for you, and I said, how are you doing? The first thing is that this man has tried. Is that not what you say? This man has tried. So even if there is pain, you say, I'm moving here. And the pain has gone down. But if I give you a questionnaire and I'm not there, I just say, please rate this thing for me. You know, I just ask you rate the pain and let me know how you're doing. You rate it based on what you think. But if I come in person to ask you, already bias will set in. Do you get it? So sometimes when you do this exercise,
There is no audio.
Sorry, let me still share my. Somebody is asking question in the chat box. Please, can you read out the question? Oh, he said the network has been so messy. Oh, sorry about that. I don't know what's happening with our network today, but we're doing our best to fix it. Can you see my slide? Can we see the slide?
Yes.
Yes, we can see it.
Okay. So I was just trying to bring a case example of how I treated a 45-year-old man with chronic non-specific low back pain who has been sedentary throughout his job. So for the first week, I started with breathing and walking exercises. In the second week, I added some core stabilization exercise and stretching. Then we worked towards the second week through third week, and with the same breathing, walking, and core with stretching until we got to the fourth week. At fourth week, we started with the planking and cardio. So, and the last 6 weeks, we started with functional drills. So you can see that each week, you should be able to design what activities patients should be coming for. So when you assess the patient and you see that they are good to progress, then you move them to the next stage of their work. Okay? I said evidence of support exercises, especially when the exercise is added with education, is superior to any type of passive care. If you have exercise and education of your patient, it's better than any type of passive care. What is passive care we're talking about here? All those therapies that patient will come and sleep. You know, the patient likes sleeping, requiring tension, short-term diatemy, laser therapy, ultrasound, and acupuncture. When they puncture you there, you shout and they leave the pain. Eh? So motor control and exercise show more stronger outcomes. When your exercise includes balancing and all those we talked about, it gives you more evidence to work. Then the Cochrane and NICE guidelines endorses exercise-based rehabilitation. So you see where your endorsement is. If you have good evidence that exercises are things you need to treat your patient. You can see, especially in back pain, you do not need to come with even one single gadget to treat a patient. He said they will not pay you. In summary, I said exercise is essential for non-specific low back pain. It should be customized based on the phase and the goal you want to achieve in the patient. We should know that whether you're giving exercise, you must educate your patient, empower them, and then you should progress mindfully. You should aim for long-term engagement and resilience in your patient. Okay? So this is where we're going to stop for this exercise. Then we'll move to manual therapy. This is where people think that is all about back manual therapy. So, okay, are we taking some break? Please, let's take some break. We're coming back. Yes, Nelson hand is up. Somebody on the physical will have a question. So let's answer the physical before the online. Yes, please. What's your question?
Usually when patients come,
yes,
their problem is pain.
Yes.
We are treating them. When the pain goes,
they disappear.
All those things, they won't come again.
Yes.
Not their problem. Just go.
Yes.
Years or some months.
Now, the person in the physical is asking the question that what he has noticed in among his clients or patients is that when they come in for therapy concerning low back pain, their major concern is the pain. I said, yes, that is the condition. Is it not low back pain? It is the pain that brought them to the hospital. But you see, the moment the pain is taken care of, the patient disappeared. They will not come back until maybe another day or another time or another episode they have the pain again. Ladies and gentlemen, whose fault is it? Did we get the question? Those online? They're following us online.
Yes, sir.
Yes, we are following.
We get it.
Following.
Yes. So, who do you think? Where do you think the problem is coming from?
Patient education.
Exactly.
Therapist.
Therapist.
Exactly. You know, you are very sure that patient education is missing.
Yes.
Yes. Somebody is asking, can you rephrase what you said about the different exercises for different stages of low back pain? Yeah, I'm not going to follow, you know. You want me to summarize everything I have said again. You know, somebody asking for now. Somebody said you have to pay for somebody again. Okay, let's see later. We'll talk about that. Yes, so this question means you didn't educate your patient concerning the recurrence. If he knows that this pain, don't feel because the pain has gone now, it will not come back. That pain is likely to come back in the nearest future. Aim and goal for your treatment now is to prevent recurrence. So the patient will know that if you stop coming, it is fault. So the patient is likely to ask you, for how long are we supposed to do this management to prevent recurrence? You know? So that he wants to fulfill all righteousness. You tell him we need it for another 6 weeks. You know, he's not having anything, but he comes until he finishes. So the day he has pain, you told me I should not do this, now there is pain. You see, so it means you tell him the issue is for recurrence. Number two is that you must avoid activities that will put your back into other vulnerabilities. If it's a disc problem, don't go and be bending your back for long. Don't go and lift or carry anything heavy. Don't go and lie down on a soft mattress. Don't go and be pushing any heavy gate or wherever. So you're giving him education, the risk factor that will lead to it. So the day he now does anything, he will now come, I've injured my back. What you say I should not do, I did. So you see, he will not accuse you. Education becomes very, very important. Yes. Nelson, your hand is up. Please go ahead.
Thank you so much, Prof. So far. Prof, please, I'm being a bit curious because having listened to the presentation, I think you've narrowed down the two areas of pathology to spinal pathology that has to do with stenosis, and the other one that has to do with the disc. Then I am just thinking, sir, there are some of these practitioners that also play emphasis on facet joint pain or facet joint problem. So do they fall under the categorization of facet joint?
Okay, yes.
Sir. Yes. So do we categorize them under this pathology, or are they different in altogether? Because I know some of them are also movement related in the way they manifest, either inflation or extension and all that.
Yes, basically the facet joint dysfunction are categorized under spinal stenosis. Don't forget the facet joint are synovial joint. And when they get dysfunction, it's all about osteoarthritis of the joint. And we know osteoarthritis is usually in the elderly, okay? Except if there's a traumatic affectation or it's a secondary arthritis. But facet joint is usually put under the spinal stenosis issues. Yes.
Thank you so much, sir.
All right. Okay. Should we quickly go and have a break and come back at 1:30? 15 minutes, is it good enough?
Maybe 1:45, Prof.
1:45?
Na shigo.
All right, so we rearrange by 1:45, please. Thank you very much, everybody.
Yes. Okay, one question. Huh? Yes, no one can yeah. Well, I have water here.
That's one sachet. Is that available? What do you want? The Kindle no, happy as well. Yeah, that was one. I need the pack by itself. I think one inside the pack. Oh, I can't remove. How much? What one can do? When you finish
No, what's all?
don't worry, you can help me.
What do you want?
Good afternoon. Where are you doing, sir? I am zinc for Asin. Yeah. Because I'm having serious reaction. I don't know whether it's the axis. I don't know whether there's any other code. I've never had it before anyway.
But that's what you want to see.
No, someone asked me, said it would help. I don't know.
Yes, it works out. The person that told you to get it, like how person told you how to
The third is the supplements.
zinc supplement. This also works. But do you want it the cup? We have zinc cup.
Let me see.
Yes, exactly. Agree. Yes, that's right. This one telling you to have. Okay, this is supplementation.
Okay. Sorry, you work here. I'm looking for acne, zinc for acne. Zinc for acne. They said that is there, but I can't. Okay, you want? Zinc supplement. You need to write it on the body for acne. It's this one I saw, but it's not this one.
Please actually have this back with
This one. I didn't see that. Okay. It's fine. Yeah, the price is so high. But there isn't really war. I'm confused. I've used a lot of things. Nothing is working. Hmm? I just heard about it yesterday, but so this morning that I started a skin doctor. Said he's not even around in a national hospital. I went to the Lagos because I wanted to see his like let him look at it. I've never had this in my life, so huh? The 10 is how much? You know my fear. My fear is that the doctor not says prescribe something else, and I've already bought. I want to feel like calling him. This one it said is conducting exam. Please, how much is of the 10? Hmm? Yes, how much is it, please? I just wish that I wish spend the money I spent. Huh? 6,000. Just a colleague, but I chatted a doctor, the skin doctor in National Hospital. He said that he's in Lagos, he's conducting an exam that he will revert back to me later. Because I snapped my face and sent to him. So my fear is when I buy something now and he says maybe he prescribes something else. Yeah. But 2 people have told me about Oxyten. But my dad said I should wait until let's see whether it's the same thing or we have something else. This is very bad. Because I bought, someone told me about products from Avil. Avil. I finished buying, spending money, and nothing is working. No, I'm not using them, but I'm very scared because the ones I bought from one product. If you work?
Yeah, now so what?
Okay.
It's what I'm using day and night.
To clear all these things. I've not had all these things in my life.
What did you do?
I didn't do anything. That's what everybody's saying. Maybe I ate something or hormonal waiting.
Because you're growing.
Hey, how old am I? I didn't grow.
You're growing. You think you're done growing?
God, oh.
You're not to 35 points.
I'm not with them. 30. I'm not with them.
This one is what? Is a cream. The cream you rub on your face. It's just annoying now. You know that it's like vitamin A. How much is it?
Just let me check how much. I might come back in the evening. Yeah. Then I start at this place. Always where I used to buy my drugs now. Here is quite affordable than other pharmacy. But this one is more costly than vitamin D and C. Zinc. I bought zinc. I bought vitamin C 3 weeks ago and yes, and vitamin D3. I noticed because I think vitamin C was 13 something or whatever. Then vitamin D was 13 something. If open on Sundays in the morning. What happened? Oh, okay. Is there any other one? Hello. Okay, fine. I wanted to. I said I'm fine. No, you said I shouldn't buy any other thing. Hello. Can you hear me? Can you hear me? Okay. I was thinking of buying the those two this thing tube that some people have, like about three people now have said that it's going to clear. I said I should wait, but that one, there's one she was telling me that is 2,000 waiting. I'm free call.
Okay, good afternoon, colleagues. Are we back? Can we continue?
Hello. Yes, I can hear you. Yes, I can hear you.
Hello, can we continue?
Yes, we can.
Can you help me, please?
Can you hear me? Am I audible enough?
Yes, sir, we can hear.
Okay. I'm just going to share my slide. So we pick it from there. Can we see the slide?
Yes.
Okay. Good. Right. So we're going to see, be looking at issue concerning manual therapy. We finished about exercises. And I said we're going to look at manual therapy. The current evidence guideline recommend that we should use manual therapy in the management of non-specific low back pain. But of course, it should not be used alone. That's what they recommend. It stated that it should just be used as an adjunct. So our objective for the use of manual therapy, number one, is we want to use it to also reduce pain and muscle tension. We want to restore mobility in joint and soft tissues. We want to use it to enhance circulation and promote tissue healing. We use manual therapy to improve patient function and quality of life. And then we use it to support movement retraining and exercising. So you can see we use it as a support for other therapies. So we know that there are a lot of different types of manual therapy. Among them is what we call the joint mobilization. This is what most of us know best as manual therapy, the joint mobilization.
I'm not hearing you.
You're not hearing me? Hello, you can hear me? Can you hear
I can
me?
hear you, sir. Yes.
Okay. I was saying the first manual therapy technique we know is the joint mobilization. And joint mobilization are just passive grade oscillatory movement or sustained glides movement that are performed within or at the limit of the range, joint range of motion. We do this mobilization to restore normal joint plane, reduce pain, and improve range of motion. According to the Maitland classification, we have about 5 grades of movement. Grade 1 is said to have small amplitude at the beginning of the range of motion. Grade 1 is easy for every person to use, and then it's just used to reduce pain. We're going to demonstrate it. Grade 2 is also a large amplitude with range, but not reaching the point where pain will be elicited. Grade 3 is also large amplitude, but we do it to where pain will be elicited because there's stiffness. That's when you move grade 3. While for grade 4, you will get to the range of motion, there is stiffness, and you push into the stiffness. And grade 5 is where you do manipulation. That is, you're going to move the muscle, the joint beyond its physiological range of motion. So this is not usually called for. It's not a safe movement for people who are not having the expertise. So we're going to see some of this movement. Example of all these movements is what you have: the central, posterior, anterior mobilization in the lumbar spinous process or transverse process. So please, we're going to demonstrate the movement now. Let's see. Videographer is not. Sorry, the videographer is coming. So please, we are going to go back to that when he comes in so that we can demonstrate. But what is this movement we are talking about? In most patients with chronic low back pain, you know, most time there's stiffness in the intervertebral joint or the facet joint, like somebody asked. So this stiffness, like I said, we will begin to have lumbar movement restriction. So what we do is to use it to increase range of motion. And the common one is what we term as the central PA mobilization or unilateral PA mobilization. So we're going to see how we do such type of mobilization or the facet joint mobilization. The patient is going to lie prone, and then you use your thumb of the hand and you support with the other thumb while you're touching on the spinous processes. You know what the Muoga called the VOP as well as the TOP. These are the things we are going to be using. The VOP, which is the vertical oscillatory pressure, is to press down into the spine, you know, with several movements. It's known that just one movement might not move the spine, but continuous movement is likely going to move that spine. So you move some typical repetitions that is going to, at the end of the day, put together a force that will be able to move the spine. According to Umuga, that is what you call the TOR, the VOP, vertical. Now, when you do it from the side, it's called the transverse oscillatory pressure. It's called the TOP. So for that, it's usually used when it's the unilateral symptom. So we're going to demonstrate all that and see how it can help the patient. So for this movement, they are basically and often safe if you have done your assessment properly. Now you will do this movement if you notice the patient have reduction in their back movement or lumbar movement. And then you will try to ensure that if the movement is stopped or blocked by a stiffness, especially when the patient begins to have facet joint syndromes, like what Nelson asked initially. So if you have that, you will have there will be a reason why we will have to put that. Okay, so please, I'll be coming back to that when the videographer comes back so that he can highlight how we do that most often. So for the high velocity, low amplitude, that is the manipulation. I said it's a quick control thrust beyond end range of motion, but within anatomical limits. You must be very careful that you should not do manipulation for an elderly spine because it can lead to fracture. You should also be careful due to osteoporosis. If the spine is not strong enough, those are going to be more dangerous for the patient. So a VOP or TOP is enough for most people when you want to do manual therapy. You don't have to manipulate. Manipulation comes with high velocity, and that forceful movement can easily lead to other complications. It is basically this high velocity of manipulation is mostly for both acute and subacute. In most chronic situations, they will not work well for the patient. So, and of course, if the patient have hypomobile lumbar spine, you see there's stiffness, okay? Hypo means there is no good movement. And when the patient already have hypermobility, what's the essence of doing a manipulation there again? There's no point. So if there's already flexibility, patient can move up and down, you don't need to do that. I said you should try to avoid cases of red flags, whether osteoporosis, malignancy, and so on and so forth. So another manipulation technique that we don't use to call manipulation is massage. It's said to be STM, right? Soft tissue manipulation. Massage is very, very important when you talk about the coverings of the back. There are soft tissues that cover the back. If anybody has ever noticed when maybe a goat or a ram is skinned, you will see a tissue, white tissue covering the muscles. That's called the myofascia. The myofascia are those tissue that cover the lining of the whole muscular structure of the body. It means they have connectivity between the skin and all muscles. So if there's any myofascial irritation, there's going to be translated into the muscle. So that is the reason why this STM, most time when you massage your patient, they tell you they feel much more better. Do you understand? So they form what you call the trigger points. Okay? So what myofascia, when you manipulate them in any type of massage situation, they have the ability to give you more blood flow. And you know, when you have more blood flow, it will take away the pain substances and your pain is released or your pain is relieved. So there are a lot of different techniques that you can use. So one of those techniques to apply to muscle fascia or connective tissue include effleurage. In effleurage, especially when a patient has sciatica that crosses between the buttocks and then the calf muscles deep down. The moment you come to start effleurage, please call my videographer. You know, it's a movement we do, not like the former APC chairman that we say from top to bottom. Is it top to bottom or bottom to top? But in this case, we are going from bottom to top. It's not top to bottom. So it means you are pushing all those pain substances to the closest drainage system. Do you understand? So if you have from the lower side, you want the first popliteal fossa, where you're going to find that you have popliteal nodes. So you're going to drain all those tissues in there, and then you move it like that. So this is what we'll be doing. So we have effleurage, the Petri sage, then you have frictional one, especially when you have trigger points. Frictional massage normally helps, especially if you have a trigger point where the sciatic nerve crosses into the gluteal muscle. You will see that when you massage those points, and this is where the effect of massage gone is good in physiotherapy. Now, instead of giving your hand also all those tension, you can use the massage gun for all those trigger points. They are going to open you up. Okay, the videographer is back. So we're going to see these things as we talk about them. So myofascial release helps the muscles to get relaxed and to increase blood flow. And we'll see how this releases are. It's the same way we talk about the frictional massage, it's the same thing we talk about the trigger point therapy. In trigger point therapy is as good as the muscle energy technique because you're going to hold the trigger point. You know, you are going to hold that position and make friction, compress the point. You know, we are compressing that point for some time, usually between 15 to 20 seconds. You are going to hold on to that trigger point until the patient tells you They are no longer feeling the pain, they are feeling the pressure of your hand. Do you understand? So it means you're trying to disperse those soft tissue, what you call defense substances that have been collected under the soft tissue. So we're going to use that, and then you do your MET, that is the muscle energy technique. You're doing trigger point and MET at the same time. So we're going to see all that as we move. I said the benefits of the soft tissue massage include reducing muscle tension, breaking adhesion and scar tissue. You know, we said the patient can have injuries, and then this injury can be for a long time. Eventually, we'll reduce the injury. We use it to improve lymphatic and blood flow, and then we prepare the tissue for movement. So before we talk about the muscle energy technique, we need to demonstrate some few things we mentioned before concerning the issue of the DOP and TOP, which I said the central posterior movement. Okay, so let's look at it. Get ready. So I'm going to expose your back. Or be able to see it up. So you can see if you want to do any movement of this patient this way, you can see that the patient may not be comfortable. Most of them that will help you put off the hands closer to the wall. So what you do is to support the abdominal region with your pillow deeply while the chest is on ground. You can see that giving you more positioning of the back. Now, don't forget, you must be able to identify the landmark. You know, in the evidence we saw in the morning, the moment we saw S5, everybody knew this is S5 because the guy is sleeping downwards, right? Now, this is in this position, you know, it is L5 that is above you. And you can count L5, L4, L3, like that until we get that. So, but how do I know whether it's L5 here and L4? So you want to demonstrate that anatomically, you're going to identify the posterior superior ear spine, the two dimples at the back. Those are your PSI. So the line that crosses onto the midline is what takes you to your L4 spinal process. Okay? Now, if you go to this region where you have the anterior superior ear, and then you drag it to the midline, is what takes you to L5. I hope you understand that. So if I'm using the PSIS, I'm at L4. So this is L4. So just one more step is L3, L2, L1. When I go this way downward, L5, S1. All right? So for this patient, I've been doing my evaluation and assessment here. I identified that the patient is having some reduction in the range of motion. Those are the simple things that you could do that your patient will respond immediately. Okay? So it's a posterior superior, we're on the spinal process. Now, as the patient, you know, during assessment, we talked about coming to do the vertical oscillatory pressure. You know, the compression test to find out if there's pain, yeah? If there's pain, yeah? So we've been able to identify that between L4 and the pain. I think that's the pain. There's a likelihood there's one. Restriction, reduction in rate of motion. So this is just common sense that involve that and increase the range of motion. So what I'm going to do there is stand by the patient. My left hand is supposed to be what is going to be, because if I'm right dominant, the highest pressure is going to come from my right side. Right? So I'm going to use my right thumb to be on what? The spinal process of L4. So I'm trying to move my L4. Okay? So I will use the right hand to support it. Now, when I try to do my movement, I'm not going to do the movement from this hand. The movement is going to come from my shoulder. My hand is supposed to stand and just support, so I don't get tired easily. I just keep doing this. It's on vibration. Okay? You see that? So the more you keep moving, the more the patient must have. So, but the question is, how many will you do before you get tired? Okay. These are those stories online. There is not have you ever had any bacteria? They put speakers and everywhere. Oh, we speak and do that and the presentations are like. It's just so easy. So, well, on this time, our essence is to ensure that we are moving the style and it has to be gradual when you start. Because the resistance you get from the start is to tell you how much you drive. The resistance is telling you that it's very good. So if I'm doing this, and I'm feeling the tissue pushing me backward, because you're not feeling it. Your hand is your ear. Your hand will be talking to you that no, you shouldn't go deep. The more you go deeper, the more irritation you create for the patient. So it's supposed to be a very enjoyable situation and enjoyable patient. So what you're supposed to do when you're here, and then we just keep moving, and then you speak to your patient out of the skill, that we can. We shouldn't see you any serious pressure in your face. There shouldn't be pressure. So as we're going, this is the DOP, vascular oscillatory pressure. Now, if this patient is a disc pathology I'm looking at, and he says his pain is related to this limb, I'm supposed to stand at the limb. It means there's a pressure on this side. So I should move the spine this way. I should not stand and move it here. I'm making it work. You get my point? So I'm going to be here. Now instead of going straight, I'm going to come to the side. You see my hand? Then I'll be doing this. Yes. So this is like a sliding movement. So we keep moving and we're talking. As we keep doing the repeated motion, it has to be repeated. So we tell you 20 times. So we'll tell you have to move and many times in 1 minute before you stop. Because the micro movement that will articulate now form a major movement. So as you are moving, you're also distorting, you're also building your patient. You're trying to find out if there is some comfort. You're trying to ask the patient how is the sensation, right? You're supposed to be looking at the neck. This is what you see. So you're facing your patient. So you ask, how are you feeling? How is it feel? You feel that sensation? Assuming the patient tells you the sensation was there before. Then as you move it, I'm feeling it up. What is that? Centralization phenomenon. Right? But when feeling this, I'm feeling no longer in the back. It's no longer at the back. It means you are losing it. I'm not getting it at all. So we should understand how this thing works. Okay? Now, the moment you will be able to do the DA or TOB based on the patient symptom, there is something that you need to do for patient that will keep the patient over the peak one. It's called the lumbar rotation. What is that? Yeah? Stand up, lie down, down on the side. The patient lie on the side, we're going to bend your knee. You see? Now, this shows you want to rotate the ankle of the elbow. The longer you open this, the over the movement position from. Okay, the center of the whole will go back up. So, applying the elbow I want you to do this. So when you are trying to do it, the patient can, or you are the therapist, will let something of this. While the patient will bring this to hand, take it off. Yes, then turn hold the hand. Turn to that side. You see? What do you feel? So this is also another option. Look up as long as most patients with back pain will follow with this. Going to open the patient will getting and you want to do this. So you repeat your assessment. That's what you tell you how to identify if what you have done is beneficial. Before doing it, what are the things the patient can do? Is it the SLR, is it whatever? You try it. Range of motion, you try them of the lumbar spine. Now, by the time you go through the VOP, TOP, rotational movement, you'll be able to know. It's not asking the patient. You go back to tell the patient, do those activities again. Before I can move my leg, oh, now I think it's free. So those are the positive signs that we need to do. Did we talk about something we wanted to show again before now? Yes, I mentioned there's SMT. SMT or STM? STM, soft tissue massage. And I said, please lie on your stomach. Most times, patient with sciatica will come with pain, especially here, in the calf muscles, in here, and maybe somewhere in the glute. Now, sorry, I'm just trying to open up this, for instance. You're not going to stand on the side. You're going to stand straight to the patient. Yes, and that's why I say bottom to top, not top to bottom. Yes. Now, before you do this STM, you're supposed to use a massaging medium. Either we're using a Voltaren cream or a cream that could aid pain, but it will allow you for your movement. So you have 3 patterns of movement. It's either we're going this way. You see? So this is the arrow of movement. Okay, we're not coming here like this. Then the next one is arrow of movement up. You see, I once had this way, then we have this, like that. This is what I say we are moving into the most closest drainage, lymphatic drainage. Okay, it goes. Patients mostly enjoy this thing because they are passive therapists. They like to lie down and then you do the job. They don't like active ones. So these are supposed to be used as half-joint, and that's what the guideline tells us, right? They are supposed to be used as, I don't know, not as the main therapy. You put this and the patient should stand up and go where? Okay, so this is the floor range. Okay, so we do it and move until we're able to go get to this. At the same time, we could also use the frictional massage, especially when the muscle is huge, like the gluteal muscle. The moment the muscle crosses into the gluteal, you can easily use the anterior superior iliac crest. Okay, we do this, the spinous process, and then an angle that crosses to this point will tell you where the sciatic nerve ends. So when you do this, you will be able to identify. The patient will shout, yes, there is pain. So in such type of pain, you just hold on to the muscle. That's like a trigger point. So you can use your hand. If it's too big, you can use the elbow. You know, it depends on what you feel. At the same time, you can now use our what? Muscle energy technique. So for instance, I want this patient to flex the knee while I'm doing this. So I will be resisting the knee flexion. You see, because it's using the hamstring to flex. Bend your knee while I'll be doing my with this. Find the muscle. Is it not contracted? It's contracted. So you put them together. Okay. Those online, do we have questions? Are they following? Online.
Yes, we're following.
Any question?
No, sir, there's no question.
Second question.
It's clear.
Let's practice. One or two. Please practice. We will still continue with the muscle energy technique. For the muscle energy technique, it's a passive therapy. I hope they that's all about the myofascia that you'll be working on. That talks about the muscle energy. Okay? It's about the patient is contracting at the same time you're trying to resist the contraction, and it's all about stretching the myofascia. So we're going to look at that anytime we have any opportunity. All right. So let's look at neural mobilization. Neural mobilization, I said, these are the nervous system that you mobilize the nervous system to reduce mechanical sensitivity and improve the neural glide. It tries to address central sensitization. Is used in patients with nerve tension, but no frank radiculopathy. What we're saying here, when you have patients that have this kind of nerve-related issue, that the back pain has to do with nerve issues, like the spinal stenosis. You understand? But at the same time, you cannot see that nerve is compressed. You understand? Or it can be a fixed problem, which it has not reached the level of nerve compression. But you have issues related to the nerve. So most times with when you want to do neural mobilization, there are two things. It's either you're doing the neural glide or you're doing neural tension release. So the neural glide is just like when we do slump test. So in slump test, the patient sit down. Now bring your hand. You just keep your hand like that. You are moving your hand. This is the tension here. And then you are sliding this while your leg is going up. You see, you'll be coming down, stretch your hand. Then opposite, you'll be bringing this one down. No, releasing this, bringing it down, the neck going up. So this is just sliding. You go back. That's neural sliding. The slump test is for a nerve fixation. So this is sliding of this one that you put the limb into dorsiflexion is what we call the neural tension. Okay? They're still gliding. This when I'm sliding, when I'm pushing this tension, I'm working on the static nerve. So that's the anterior compartment, no? That sorry, that supplies the anterior compartment models of the lower limb. What the expectation is that they should be released as they are doing the movement, the tension in the nerve to be released, to be relaxed. This movement, they are sliding the nerve, so the nerve should be totally released. It should not be tensed again, because it's a repeated movement to be doing. Okay? You can also do it in different positions. Let me show you some other positions that we have. So you see in this image online, the patient can just do like this, right down. Now lift the leg up. I can put maybe like, if you know what the Mulligan technique is, this smart and what snap. You know, I have a Mulligan belt here. I'm holding it. I can pull against it. You can pull it back. So you as a therapist can also hold hand behind the patient like I put my hand. Push, you know, you are strengthening, you are also stretching the nerve. All these are neural mobilization. Okay? Yes. So I said manual therapy should be patient-centered and evidence-informed. Whatever type of manual therapy you want to use, will that patient benefit from it? Okay? So it means it's not every patient you must say you must do your manual therapy technique for. Number two, will the patient benefit? Okay? And then do we even have evidence that thing will work for this patient? Do you get the point? So these are the things we should be looking at. And I said your manual therapy should be guided by your physical assessment. The assessment you have done is what should guide you. And then we should combine it with education and exercise. So you can see that whatever you are doing, whether it's acupuncture, whether it's what is the name? Whether it's manipulation, what you must add exercise and education. Okay? So I said we should adapt them based on the symptom irritability and patient response. Contraindication we should be wary of. There are some things we should see that should not make us try to want to do manual therapy. Number one, if you suspect a fracture, malignancy, or infection, please, when you suspect, don't do it. As long as you are suspecting, don't do any manual therapy. Number two, if there is osteoporosis or severe osteoporosis, please don't do manual therapy. Number three, if there are issues of caudal equina syndrome, that the patient can no longer hold urine, the patient cannot hold feces, there is no bowel control, no bladder control, don't do manual therapy. Of course, if there are other systemic diseases that will prevent you, we should not do manual therapy. I said, let's understand that we should be able to integrate manual therapy with exercise. If you do that, it will provide you opportunities to reduce the pain more, and then it will allow for more movement. It will help the patient to move from passive therapy to active therapy. And then it will enhance the effectiveness of the motor control and strengthening programs you want to do. In terms of evidence-based, there is only a short-term benefit that manual therapy can benefit for pain and function. In the long run, it will never do anything again. And they say the best outcome of manual therapy is only when it is combined with other active interventions. Okay? So please do not use it as a stand-alone solution. And it should be part of other multimodal treatment plan. In general, I say manual therapy is valuable or is a valuable tool for physiotherapists to have in their toolbox. A variety of techniques address different aspects of non-specific low back pain. The effectiveness of manual therapy depends on proper assessment, application, and integration with active care. So therefore, patient education, assessment, and progress tracking are all very essential. So this is what we should know as we move. Now let's see the pain management strategy. This is where our other modalities come in. Shortwave diatemy, TENS. So you will see that as HODs, as decision makers of department, would you rather want to buy a machine or shortwave diatemy for 5 million, you know, than to build a gym with functional equipment? So you would prefer that you have a better equipment in your gym and exercise lab than for you to have just one shortwave diatemy just to treat pain. So we say pain is a complex and multifactorial experience, especially in cases of non-specific global pain. Effective pain management requires a biopsychosocial approach combining physical, psychological, and social interventions. Physiotherapists, as we are, we play a key role in addressing pain through education, manual techniques, exercise, and behavioral strategies. So we must try to understand pain based on, number one, the type of pain. You want to treat pain. If you don't know what type of pain the patient is presenting, treating that pain can be very, very difficult. Imagine who presents to your department and tells you her back has been paining her for the past 3 months. And that pain has never been going down. But the patient never told you that she just got divorced after that 3 months. What do you think is the pain? Is it the pain of the back or is it divorce pain? So you see, you must understand, is it a psychological related pain? Or is the pain that is just coming from the biological aspect only? So they said we should know we have nociceptive pain, which is linked to tissue injury or inflammation. We also have what we call the neuropathic, which is from a nerve damage or compression. Of course, we have what we call the nociplastic pain, which is as a result of altered nociception, which does not have a clear tissue damage, like what I just mentioned. That's what you call nociplastic. You know, she's having a back pain that interacted at the same time that you lose a $5 million job or you lose a $5 million contract. You can imagine those kind of pain. You're having pain because they stole your car. You have to be trekking. And you think it's the pain of the back or that trekking you are doing because you don't have the car anymore. So you must understand what type of pain you are dealing with. I said we should also look at pain from the mechanism of non-specific global pain. We already defined pain as a what? You know, according to the IASP, they mentioned that pain is an unpleasant experience. You know, it's an unpleasant experience. Nobody likes it, which shows either a potential tissue damage or an actual tissue damage. So anytime you have pain, it calls for concern. So this pain, we call that peripheral sensitization or central sensitization, or pain as a result of fear avoidance behavior, or maladaptive, the conditioning of maladaptive movement patterns. So all these could have been the mechanism why that pain is there. So whenever you see this pain, you must be able to establish, is it a peripheral sensitization you are dealing with or a central sensitization? When we say peripheral sensitization, what are we talking about? Who has an idea? Peripheral sensitization and central sensitization. What are we dealing with? Anybody? Is somebody there that is bothering us? Can you please mute yourself? Okay. Okay, thank you. I was saying that we need to understand what mechanism of pain you are dealing with. Did peripheral sensitization or central sensitization? What an idea are we talking about? Yes, please.
Let me try.
Please go ahead.
Okay, I think when we're talking about central sensitization, like the pain is coming from maybe the nerve root and then peripheral.
Okay. So when it's central,
the pain is coming from like the nerve root.
Is that the central or the peripheral?
The central.
So if it's the peripheral, where is it coming from?
The branches.
So can you demonstrate an example? What are you talking about? The nerve root and the branches? How do we see that in a patient?
I'm trying to think of something. Okay, if we, for example, in case of sciatica, the sciatic nerve.
Yes.
The pain could be coming from the nerve root, like the sacral region. Maybe there's an impingement around that area, or the impingement could be, or also in a case of injury to the common peroneal nerve. I don't know if it makes sense.
Hello, sir. Let me help you.
Yes, please.
All right.
Please go ahead.
All right. So let me just take it from where she stopped. So when we're talking about centralization, for instance, in the case of a low back pain, when the pain is decentralized at the lumbar, so if there's no radicular symptoms to the limbs, then we'll be talking about centralization. Then when we're talking about peripheral, maybe there are radicular symptoms to the limbs. Then we're talking about the pain is at the peripheral.
Okay, we're close by. We're almost getting it, but we want it to be very clear how people will understand it. You know, when we look at this,
sir, I want to try, sir.
Okay, go ahead.
I want to try. There are sometimes when the patient comes in and they tell you they're having pain in the foot or in the knee, but you know that it's because of radicular pain. So the patient is actually sensing the pain in the knee or the foot or the calf. And sometimes they will tell you, oh, I don't have any pain in the back. But after your treatment, they say, oh, the pain has disappeared from my knee or my foot, and now I'm feeling it in my back. So that will be central sensitization of the pain, and the peripheral sensitization will be when the patient is sensing the pain in the extremities.
Yes, I think what you guys are trying to explain and demonstrate is following the centralization and peripheralization phenomenon. But that's not what we mean when you talk about peripheral sensitization or central sensitization. Yes, please, go ahead. Try.
Okay, I think when we are talking about peripheral sensitization of pain, it has to do with maybe potential damage to an area. Maybe there's an injury, probably somewhere in the body, either in the lower limb, and it's causing the pain. Then in central sensitization is more like from the CNS, central nervous system, maybe a psychological issue that is now giving somebody an idea as if he's feeling pain.
Well, I think we're all correct. It's just at the looking at the perspective, the way we're explaining it. Like the word peripheral, of course, like all of you have rightly said, it's something away from the body. So when we say peripheral sensitization, is you're trying to relate the pain to either some sensory nerves, okay, that is coming out of the cord. It's coming from the spinal cord. It's not coming from the nerve root, but from the, it has come out of the nerve root. Now it's following either a myotome or dermatoma supply to do what? To sensitize a tissue where it's been affected. So that is peripheral. It's trying to show you that pain is a sensory affectation away from the origin. It's not in the brain. While when you talk about central sensitization, it's in the brain, and then it means the way the patient will present to you, the pain could be so much that it's been interpreted in an exaggerated manner. For instance, a normal handshake, is it supposed to give you pain? Just to shake your hand?
No, sir.
Is it supposed to come with pain?
No, sir.
That's what you get when you have allodynia. We know allodynia, right? Allodynia is that heavy sensation of pain by mere touch. You just touch your patient and he shouted, this pain is too much. It should tell you that that patient is having a central sensitization. It means the patient has what you call hyperalgesia. I hope we're getting it. So when you talk about the peripheral sensitization, it's just telling you that this pain is coming from a sensory aspect that is not in the brain, but a peripheral aspect of a nerve root. And that's what we talk about, all that sciatica and the what you're saying in terms of nerve root affectation and all that. So that's peripheral. So when you talk about central sensitization, it's the pain coming from the brain. It can be exaggerated. It can be as a form of allodynia and all that. So you need to know where the pain is coming from so that you know the best way of attacking the pain. A pain that is more of a central sensitization. Do you think it's shortwave diatemy and your tens and whatever that will work? No, what will work? You begin to talk about your CBT, you know, the psychological management. Do you understand? Because you know it's in the brain. Just like when we said a woman was divorced and she's telling you she has back pain. The moment you touch her, she will shout. You know that is a central sensitization. It's not talking about the ordinary pain she's having here. So we have pain due to fear avoidance as well. You can see it's not TENS and short-wave diatemy or ultrasound that will take care of fear avoidance. You have to bring the patient into education, you know, and then psychological treatment as well as exercises. And of course, deconditioning and maladaptive movement patterns. All these ones, like, is it Noah? What's his name? Somebody asked a question in the morning. What's this man's name? Nelson. Yes, Nelson. So Nelson asked the question that somebody has this spinal stenosis. Are we still going to allow him to be in that bad position? So these are issues we have to deal with. We're not going to allow him to be in bad position, but we have to deal with other things that will make him upright. That's what we're talking about. So in such situation, assuming it's fear that is not making him to come upright, you know, we have to deal with the fear, you know. And for most of us, like I said, it's the medical doctor that will have made your patient to be deconditioned. And then you have this maladaptation pattern of movement that is stooping forward to move. That's maladaptation, you know. So you need to work on all that. So please, it has to be a holistic approach. That's where I'm going to. So the goals of pain management in non-specific low back pain is to reduce the pain intensity and improve comfort. We should be able to restore function and movement and then address psychosocial contributors. We should enhance the patient's self-efficacy and coping strategies. and then prevent recurrence as well as prevent chronicity. So I say the key management, the key pain management strategies is number one, patient education and reassurance. If you remember, this is the first thing, our first line of movement according to the current evidence guideline mentioned. Reassure your patient. So you said you do patient education and reassurance. He said you should empower the patient with knowledge and reduce the fear in that patient. And you know, most time we don't do this. Please let this be our take home. At least if we have not learned anything today, we should go with this home. And they ask us, how are we going to teach them? What should we teach them? I said the first thing you should do, let them know that this back pain is a very common problem. I should let them know that it is not a dangerous problem. It's really dangerous. You know, if you tell the doctor, you don't know the pain I'm going through. Well, if you know this problem, let them know I understand. But I just want to assure you, I used to tell my patient, you know that back pain will never kill you. He said, I said, well, life will never kill you. Something else will kill you. The only thing back pain can do in the worst case scenario is to do what? Make you disabled. It's disability, but it will not cause death. Okay? And I told you that you should let them know that hurt doesn't mean harm. Because you have pain, it doesn't mean something is happening and scattering your back. No, pain does not always mean damage. So we should give them this information. And we must tell them the importance of staying active and getting engaged. That when you are active and you are doing something, sometimes you tend to forget about the pain. So these are realities. What method should we do? Give them this information. There's sometimes verbal explanation, like most of our clinics. You know, in Nigeria, our most difficult thing is documentation. But in the UK, the highest job you will do is documentation. In the whole day, maybe you treat 3 or 5 patients, but you will write that your hand will start paining. You think it's exam. Ask all those our friends in the UK. That's why the job is not really an interesting job in the UK, because they want you to always document. Here we don't do documentation. Patient seen, continue treatment. Continue management, we write continue management. So when somebody comes to pick our documentation to see what do we continue, we will not see anything to learn. Even me that treated the patient and I said continue management, I did not write what management. So I will forget. Maybe my wife has scattered my head that morning. When I come to clinic, I will just do what I think I should just do for this guy. But if we document everything, it will be easy that, okay, I've done ABCD. Do I want to progress to EFC? EFCD or whatever. So you will know how to move. But we don't document. Please, let's try to document, especially in our private clinics. They say we should try to use visual aids, audio visuals to do our pain neuroscience education. That we should show our pictures, images, or videos that will be letting patients know that it's not that pain means harm. Not that, let them be seeing it so that their brain gets used to it. It's not a big deal. Okay? And then we should have written leaflets. These are all ways we can pass the information. Other strategies is in the use of exercise therapy and manual therapy that we have discussed before. Of course, there is CBT. The CBT will address the psychological barriers in terms of reducing fear, catastrophization, and then working on their low mood. What is the physiotherapist's role in all this? Because the physiotherapist, is he a psychotherapist? Is he a clinical psychiatrist? No, but what we should do here as our physiotherapists is to recognize that maladaptive belief. For instance, a patient tells you that in our family, if you have this back pain, it means you are gone. That their family, they are farmers. So any person that comes to say he has back pain, that person in the family is gone. So they will just, ostracize the person. So you see, there is a maladaptive belief. So you must have to let the patient know, look, it's not for you to be telling him that it's not correct. is for you to give him that confidence that you know the fear why your family is saying if you have back pain, you are gone. It means you are going to be useless. You can't work in farm again. But let me tell you, when you have back pain, all you need to do is to change your type of farming system. Instead of using home, with a standing thing, we show him so many economic structures, and he will see the reality that, oh, I can still be useful. So the person will accept what you are saying. It's like to say, I'm a cleaner in this office, and now they say because of my back pain, I cannot clean. I'm gone. So everything you want to tell the patient must be something that will bring her back to her job. You get my point? So you don't just provide this information, you give them adaptive, something they can do to know that they can return back to work. We should use motivational interviewing. So we should be very positive and optimistic. We should not allow the patient because they are broken down and then you break down with them. And that's why your patients are not looking for your sympathy. They are looking for empathy. What's the difference between sympathy and empathy? You know, sympathy means when you go to your patient, oh, sorry, yeah, sorry. Most people don't like sorry. What will your sorry do for them? But they want your empathy. Empathy means put yourself in their position. If I were the one in pain, what would I have done? You get my point? So it's not your sorry at the end they want. It's that active measure. If I have pain, this is what I think I should be doing. This is what I should do for the patient. That's when the patient becomes happy and relating to you. Okay? So we should encourage positive coping system, and then we set goals. And we say, lastly, you refer the patient if there are severe issues or or a pain specialist. I said there are a lot of adjunct modalities from heat and cold therapy, from TENS and different stimulators, dry needling and acupuncture. All of them may help you reduce pain and promote relaxation. So it all depends on what works best for you. Okay? Sure. So the major, we should also know that there's some need for pharmacological consideration. There are time patients will come to you, they need a quick fix. Okay? Your patient comes saying, I was trying to bend down to pick something, I hit my back on the side of the chair. I can he has created an inflammation there. So we must give an NSAID. Okay? The NSAID will help boost the psychology of the patient, and then eventually the patient will be able to do what he needs to do. There's multidisciplinary and biopsychosocial integration. We put all this together. We should be able to collaborate both with the doctors, the psychologists, occupational therapists, the pain specialists or anesthesiologists. All we want is a holistic approach. Never think one person can do all. For back pain, all hands must be on deck for us to solve the problem of the patient. So you must talk to the patient. Of course, we have the issue of return to work or return to activity. So the rehabilitation is that whatever we have done for this patient, we must be able to return him back to his normal activity or return him to his work. We say returning to activity and work is a critical component of recovery for individuals with non-specific low back pain. While pain relief is often number one, is what we prioritize, restoration of functional capacity and reintegration into daily activity and work are the key rehabilitation goals. I'm sure in our last class, we discussed which one are we going to prioritize, relief pain or increase function. When a patient comes with low back pain, which one do we do? Relief pain or increase function? He said, if you want to increase pain, we may miss function. If we want to increase function, we may miss pain. So which one do we do? Which one is the most important one? I think that day we say we should not leave one for the other. It must be a combo in trying to relieve pain and also improve function. But the function must be one of our priorities, because your patient, if the moment they say they don't have pain, is the function they look for. Do you understand? Yes. So I said physiotherapists are instrumental in guiding patients through this process, and confidently we can do that. So why do we have to focus on return to work? Number one, we want to return to work so that we prevent conditioning and disability. We want to maintain the psychological well-being and self-esteem of the patient. The moment your patient can return to work, they feel what? They feel that, look, they are better now. Now you can make more money. You know, if a patient who works in FIRS, you know that is a revenue service. Every day he goes to work, he knows how much he makes. And you are not telling him to sleep at home, he should not go to work. He knows where the trouble is coming from. Even as is going on his head. So he knows that if you are able to return him to work, in fact, that's when he has getting what he wants. So we say we should support economic independence, reduce risks of chronicity and long-term absenteeism, and then we should align this with evidence-based guidelines that promote a return to normal routine. There are some barriers that will not allow us to return to work. What are those barriers? We need to know them so that you should be able to counter the barriers. The first barrier is the physical barrier in terms of pain and stiffness. If you don't work on pain and stiffness, your patient might not be able to return to work. The second one is mobility and strength. The patient cannot serve the mobility and strength to move. You may not be able to return the patient to work. At the same time, if there is fatigue and poor endurance, your patient may not return to work. Then we talk about psychological barriers, which talks about the fear avoidance belief. If I walk, I will hurt my back again. So if you don't deal with all that, the patient will not go back to work. Of course, catastrophization of pain, that the thinking that this pain is going to be getting worse day by day is also a problem if you don't work on it. And then when the patient does not have self-confidence at all, this will also lead to a problem of return to work. I said anxiety, depression are also things that will draw the patient not to return back to work. So the clinical approach that we need to use to facilitate return to work is educate your patients, emphasize activity is safe and beneficial. We should be able to explain the nature of low back pain. We should be able to address the myths and misconceptions about rest and injury. And then we should be able to promote graded exposure to field activities. So it means the patient must have to learn how to return back in a gradual situation. These are all activities that this individual must do to go back to work gradually. Lastly, we must have a functional goal setting. What do we need to get at what time? So I said our goal should be patient-centered goals. What do this patient want? We should be able to establish that meaningful goal. And then we should be able to identify that those goals are functional requirements for their job or daily tasks. I said we should use the SMART acronym to fix the goal. That is, your goal has to be specific, measurable, achievable, relevant, and time-bound. For the graded activity and functional training, it's all about reintroducing those movement and posture that the patient use for their work and activities for daily living into your training system. And then you go to gradual progressive loading strategies like lifting, standing, and sitting tolerance. And of course, we do functional capacity training. So all these are what you will use to wake up your patient to return them back to work. We should be able to recognize and address yellow flags. That is, if this patient have job-related fears and issues as well. And then we should be able to reassure and give the patient positive reinforcement. We say relaxation, breathing techniques, all these, they help patients to get used to their activity. And then we should be able to encourage problem-solving skills. They say returning to work must have a plan. And this plan has stages. The first stage is the early engagement. So when you return to work at the first stage, we'll discuss And what are the expectations within the first visit? You know, what do we expect you to do at work? So we tell you gradual resumption with adjusted roles. Don't go back to that place that money is. That's where you really want to do. You have to go back to work. Maybe sometimes you don't need to go out for where the money is. You be relaxed, you know. Then you gradually modify your duty, and then your work hardening will continue as your physical conditioning is increasing to match the job demand, and eventually you have a full return to work. So you should be able to collaborate with your employers so that they will give you the job demand. Your employer should be able to tell you what job you should be able to do, or you should be able to tell the employer, this is please what I can do for now, so that with their consent, they know your job demand, they know the type of modification and accommodations you will need, and then they have flexibility for your work schedule. So all these are things you have to discuss with the employers. And of course, you should be able to use most of the occupational health services in terms of the occupational therapies, the case managers, the ergonomics, and others. So all these are people that will help you return to work. When you return to work, you should notice that there are some red flags that may not allow you to work properly. If you find them, you need to complain. For instance, if you have a pain behavior that has been inconsistent with findings, that is, your pain is still there that is bothering you, or when you see you have left your work for over 6 weeks, it may not allow you to return back to work quickly. Of course, when you are doing passive coping strategies, most of what you do, people around you, please pick this for me, pick that for me, or do this for me. So those are passive coping strategies. They may not help you. So if patient come in with high psychosocial release, like you don't have poor support, your husband is no longer with you, or maybe you have to pay some debts and all that, all these are red flags that you may not return back to work. So the outcome measures you have to use, you should be able to monitor the progress of your return to work. So there are a lot of questionnaires like the ODI, FABQ, the Pain Self-Efficacy Questionnaire, and the Workability Index should all be used. So the last thing we'll be doing now is to set up a case for us to see how we can work on. So please, this is our last casework for today. I want us to divide ourselves into 2 groups, and then we should be able to explain this group by group. It is a 40-year-old nurse with 6 weeks of non-specific low back pain. The nurse is very fearful of returning to her work due to pain while lifting. I want us to discuss how you will assess the patient, and then how you will design a return to work plan for the patient. So please, let's see, how do we do this? We just agree who are those in group 1 to answer the group 1 question and the group 2. Let's quickly do this so that we can all go and rest. It has been a long day. Yes. Are we still there? Happy? Are you hearing me? I want us to quickly answer these 2 questions and leave. Okay, any person who wants to answer the first question? Does anybody want to respond to the first question? Everybody's tired. Though. What is happening? Can you hear me? I don't think people are hearing me.
Yes, sir, we can hear you.
Oh, thank you. Nobody has spoken long ago. So please, let's look at that and respond to it quickly. I said she's a 40 years old with 6 weeks of back pain. The patient is fearful of returning back to her work due to pain.
Yes, sir, we can hear you.
She said her pain is there while lifting in the ward. How will you assess this patient? Yes, who can tell me? What does the assessment, what is it all about? How do we assess the patient?
Please, sir, we didn't get the case scenario very well, sir.
You didn't get the pain scenario very well?
Yes, sir.
She just told you that she has pain while she's trying to lift a patient or lifting anything in the ward. So, and she knows that as a nurse, her job requires lifting. So she's fearful of returning to work because she knows she's still going to lift. I'm asking you, how are you going to assess the patient?
All right. Hello, can you hear me?
Yes, I can hear you.
Okay, let me give it a try. So, good
Okay,
afternoon. Thank you very much for this seminar. I've learned a lot throughout the process of this seminar. So, first of all, in this kind of case, first of all, I would have to do my subjective assessment, taking down the patient history. Now, in taking down the patient history, I have to be very attentive to the patient's age, the patient's occupation, which you already mentioned, then the type of work she does, where she lives, and then we'll start talking about the pain, how she feels the pain, what aggravates the pain, what is it called? What relieves the pain? Yes, which activities that she does that relieves the pain or increase the pain? At what time of the day does she normally feel that pain? Whether it's in the night, in the morning, or get all those informations. Then I'll now move to my objective assessment. So in my objective assessment, I'll have to do the physical examination. A physical examination such as the straight leg raise, the fibers, the cross straight leg raise, like you mentioned. Then I have to get all this information, the slump test, then all these things. And then from the question you already mentioned, you mentioned something about her having pain
while trying to
lift, which means on extension, which means most likely the patient on flexion doesn't feel the pain, but on extension, the patients feel the pain. So I get those informations too. Hello?
Yes.
So I get those informations too. Then after my testing and all that, then I also check the X-ray to be able to pinpoint to where my physical examination, to confirm what I observed in the physical examination, whether it's disc issue, pathology, or whether it's stenosis. Then from what the little information I got from the question you asked, on extension, the patient feels pain, which is most likely, which is most likely that the patient on extension, when the patient, and then from the patient's age, sorry, I didn't get age again.
Age is 40 years. The age is 40 years.
The age is 40, that should say is not disc problem, it's more of stenosis. It's disc problem. It's disc problem, not stenosis. Disc problem, sorry. I beg.
No. Okay, go ahead, Otto. Otto, are you still online? We're getting you. We lost you at a point. Okay, Franklin, go ahead. Help him.
Okay, sir. Thank you, sir. All right, for this case.
Hello?
Yes, we are with you.
Okay, so I said from the age.
Yes.
Are you with me? So from the age, it's already pointing to me that it's most likely a disc pathology. And then also from on extension, she feels.
Is that Otto that came back?
Yes, it's Otto. It's Golden. Yes.
Okay, Golden. Okay, go ahead. Then we take you back. Okay, after Otto. Go ahead.
Okay. So I said from the age already, it's pointing to me that it's a disc pathology. Then also from on extension, it means that it's most likely a disc pathology. So all of them are pointing to one direction. And from my physical examination, I might be it might be pointing me to that same direction. Do you understand? Yes. So from all these aspects, from these things I've gotten, these informations I've gotten, then I will now be able to plan out my treatment for the patient. And then
before you treat your patient, I want us to establish a diagnosis. And that diagnosis is, how does her job relate to the problem she's having? Do you think her job is a risk factor to the problem she's having as a nurse?
Yes.
So what risk has that job predisposed the woman to?
Okay, in nursing profession, most of the activities are bending on flexion movement mostly. Hello?
Well, with you, we're listening.
Okay, so I was saying, so from what from her complaint, so yes, from her complaint, so it's a challenge already. It's a challenge already. Her pain and all, and to her work, for her to get back to work. So I have to be able to plan out treatment.
Mr. Golden, do you want to ask this man to quit her job? Are you going to get her another job?
No. I think I will need help here.
You see, you are only trying to rush into treating this patient, like what most of us as physiotherapists will do. And that's not the idea. The idea is to establish how did her job put her into the risk of that problem. Now, how do we take away those risks is what we should be talking about. Because if you don't take away the risk, you treat the patient goes back to the same job, and the problem comes out. Because she tells you that she's scared of going to work because she knows she will lift a patient and the pain will come back. So because that's the answer to your question, to the question. So I want us to see, how do we relate, and between her job and the primary problem she's having now. Okay, Kay, you want to help Golden? Yes, say something.
Thank you, sir. Thank you so much for the lecture. So far, we have gained a lot from it today, sir.
Yes.
Thank you, sir. Concerning this patient, sir, we just like after we will start with subjective assessment. That's after taking the patient biodata.
Yes.
Yes. So we start with subjective assessment. But here, some little information has been given. We heard that the patient was trying to lift. She was trying to lift a patient and then sustain the back injury. And then the patient was afraid of returning to work after 6 weeks. And the patient is 40 years old. So now we have an idea of the mechanism of onset of the pain. And some other thing I would like to know about the patient is what is the degree or severity of pain? And then I also want to know the location of pain, of that particular pain. I would like the patient to point to that area where the patient is having the pain.
But all this information you are looking for, they are inferred in her concern. She tells you she has a pain, and that pain is so bothersome that she's even scared of going back to pain at work. It means that pain she's having is between a moderate to severe pain. It's not a mild pain.
Yes, sir.
You get my point? So it means, like, I just really needed you guys to point out that this is her job. Otto has mentioned that her job requires frequent bending, lifting, and all that. Now, all these activities, how do they predispose the patient to back injury? That's what I want somebody to explain.
Okay, can I say something, Prof?
Who is speaking? Nelson.
My name is Nelson, Prof.
Okay, yes, Nelson, please go ahead.
Well, by my own perspective, the problem is not really with her job.
Okay.
Even though she has a repetitive movement, which she does by virtue of her job, because after all, there are other nurses that do the same job and they are not coming down with low back pain. So
we lost
I
you,
think
Nelson.
my concern will now be on postural training.
It's obvious you're speaking from your mic, but you're not audible again. Or is it only me that I cannot hear Nelson?
Am I being heard?
Okay, I can hear you now.
Okay, Prof. So what I'm saying is that there are other people, other staff that do the same kind of job she's doing, and yet they are not coming down with low back pain. So what I think my intention will be is proper education on proper lifting techniques. Lifting techniques which she may not have had the privilege of knowing, and also to assure her that for the fact that she has pain doesn't mean that she cannot go.
Nelson, you said proper lifting technique.
Yes, Prof.
Proper lifting technique at home or where?
Well, but at the workplace, because that is where she's
that you know that is one of the problems at her workplace.
Yes, it is one of
You're trying to contradict
it's
yourself. You said if it were you don't think her workplace is the cause of her job. But you say you want to teach her proper lifting technique.
No, Prof, what I'm saying there, the job is a risk factor, no doubt.
Yes.
But I also think that it's not everybody that does the same job she does that come down with low back pain.
Yes.
So what may have given her the low back pain is maybe the wrong technique of carrying or lifting patients.
Exactly.
Even that working in the hospital as a nurse is a risk factor, but she may not have the proper education or training on the proper lifting techniques. So that is the area I'm looking at.
Yes.
And education.
Just hold on, so that we want to carry our colleagues along. Like I said, the question is our ability to identify the risk factor of her job that is likely to predispose her to the low back pain. And I say we should not manage this patient until we're able to identify those risk factors and then take them out, you know. And now, if you agree with me or with us, what we have said earlier, like Golden Author mentioned, that her job as a nurse requires consistent and continuous bending as well as lifting. This could predispose her to disc pathology, which is very, very true. And I said, if this is the truth, if this is the case, then what do we do? And it is the solution you just provided now. For us to manage the patient is, number one, educate her on proper lifting technique, on proper bending and postural technique. These are the things we need to educate the patient. So we need to teach and train her on proper lifting. If we do, that's where we can create the confidence, and then we can teach her how to return back to work. Because those are her fears. So are we together in that case?
Yes, sir. That's correct, Bob.
Yes. So the second aspect of this question is asking us, okay, we should prepare and design a return to work plan. What are we going to plan for this patient to go back to work? What do we plan for the patient? How do we plan? What are we going to do in our design? A work plan, return to work plan. You know, I put up so many things so that it doesn't look like a story to you guys, but I brought up just the most important thing. This nurse has a problem. A nurse needs to go back to her work, except if you guys want to give her a new job. And everybody said they can't give her a new job. So we need to take her back to her job. And we said the first thing we need to do is that she says she's scared of going back because she knows she's going to lift. And her pain normally comes from lifting. Okay? So, and we said the first thing is to teach her a proper lifting technique. Now we have agreed. So, but we said, let's plan a return to work plan for her. What do we do? What is the first thing first?
Hello, sir.
Yes, please.
Yes, sir. Since we have already, let's say we have already given the woman education, we have already educated the woman on proper lifting techniques.
Yes.
Then if she is returned to her work, there needs to be the consent need to be taken from her superiors that she job modification. Let's say any other thing that may.
So are you going there to her office to take it?
No, sir. We explain to the patient. If you go there,
you have to be very careful in all this. Sometimes when you say this to the patient in terms of job modification, sometimes you have created more fear into the patient.
Okay.
That you may not be able to do this work again. So you're now saying, please change my work. Let me go back to this. No. The patients will be educated on gradual return to work. Now, in gradual return to work, it's not every activity you will do. So you go gradually. We don't go back by going to do bed laying. I think you should tell your superior that you'll be doing the reporting and maybe dressing of patients. That subsequently, in your plan of returning to, you'll go start by bed making, from bed making, before you begin to do anything lifting. You see, it means the superior knows that there's a time to go back. So it's not that we're going to call the line manager. Or that if you're not, we want you to change her from lifting to. We'll now write that there is not handicapping or a disability. Please take her away from here. So when the hospital wants to do forceful retirement, they will just bring her name first. She have done her to Masaki. So please, that's not what we'll do. I want us to design the plan. And unfortunately, our time is only remaining 7 minutes to wrap up. So I don't know, Chidebere Prince, you wanted to say something? You and Jukes, do you want to
bend it up?
go up?
Down, push.
Jukes, Iwuchukwu and Chidebere Prince. I saw your hand up before. Your mics were open. Do you want to say something still?
Up.
Isaiah, do you want to speak?
No, ma.
Okay.
Push.
Mustafa Ahmed, please mute your phone, mute your mic. Abdullah Shehu, mute yourself.
Okay, sir.
So I was thinking we all understood when I talked about our plan. The plan is going to be this design. You're going to manage your patients with what? Exercises, strengthening, endurance. You're going to add the biopsychosocial approach. You're going to talk about those things that will take away her fear. We're going to educate the patient, like we talked about economics and all that. So all will be included. Then we talk about gradual return to work. What do we do first? This is why you start going back to work. You start your activity gently. You start by going to work and writing reports before you move to now making bed. You do dressing, then gradually before you begin to lift with patient. If you want to lift, you have to lift with about 3-4 nurses and patient relatives. Don't ever go trying to lift a patient yourself. So we train her and educate her on all this. So we've and tell them this plan is going to be a 6 weeks or 8 week return to work plan. The first 2 weeks, we're going to be on aerobic exercise. In the 3rd week, we're going to be on this. On the 4th week, we're going to be on that. So this is what I mean by planning and designing a return to work plan. I hope we all do understand this. Ladies and gentlemen, we have come to the end of non-specific low back pain. I hope we've been able to do some few justice to it, and I believe that we are more confident if we have taken the course from module 1 to this 3rd one, that will be more confident and more professional in handling our patients with non-specific low back pain. So please feel free to ask questions irrespective of module 1, 2, or 3. So if you have any question, please, the floor is open for the question and answer session. Thank you very much.
Thank you. Thank you, sir.
Yes.
Okay, Prof, can I ask a question?
Yes, please go ahead.
Thank you so much for the presentation. Prof, my major concern is our role in management of patients with a lumbar stenosis. Because honestly, as a person, I discovered that most of these patients, they come to us as the chronic
stage.
Chronic phase.
Yes.
Yes. And based on that, it becomes difficult for us to do a whole lot of things that we should have done at the acute and subacute phases and all that.
Exactly.
So my question now is for those patients that come at this period, what are the prognosis that we actually could get them better? But I know there are some personal patients I've been managing, and over time, I've not really been able to see much improvement despite all that I have been doing. So it keeps me worried about it. Yes. So that is a challenge. The other thing is any magic we can do to ensure that we get better.
Mr. Nelson, I can feel in your tone the disappointment and the worries you carry in your heart based on how these patients the trouble they go through. Of course, first and foremost, is because we do not have a healthcare system in Nigeria. Everybody just does what they want to do. Nobody is held accountable, or nobody has the responsibility of doing things right. Now, like I mentioned earlier in the presentation, most times the doctor will only send you the patient when all medications, everything has failed. He doesn't know what to do, or he wants the patient to go for surgery and patient refuses, maybe due to no money, then he's like, okay, go see the physiotherapist. And at that point, everything is collapsed. But the good news I want to tell you is this. Most of the things we learned at our school days, during our undergraduate days, are really not the right things we are seeing in clinic. And I want to believe from this time onward, if we go back, I will try to institute most of what we have learned, and we may see differences. I want to believe we may see differences. So please go back, review your patients, and try to see what it is you have been doing wrongly, what it is you have not been putting in the right perspective, and see. I want to assure and believe that you want to get a better prognosis and outcome. Like your prognosis depends on the strength of your assessment and evaluation. If you don't get a good diagnosis, you're not going to get a good, the correct treatment strategy. So please, let's go back and put what we have learned into practice. And I believe we're going to see some changes. Thank you so much.
Thank you, Prof.
Yes, any other questions? Somebody posted something. He says, let me see, TOP. My question is, in the case study we used, the nurse had a disc problem. We were not very specific. We didn't say the nurse had a disc problem. A lot of information has to come before I talk about disc problem. So please don't take one or two things and claim disc problem. You saw many things. I talked about clinical criteria, physical criteria, and the imaging criteria. So there are a lot of things you have to put together. Don't just do one or two and make diagnosis. So please, I didn't say the patient has a categorical disc problem. You just infer, okay? So with that, we expected pain on flexion, but why does she have pain on extension? I didn't say the patient has pain on flexion. I didn't say the patient has pain on extension. So please, those are all your judgments. And this is what I just mentioned to Nelson. Let's go back and review our patients very well, put what we have learned into practice. Mr. CP, the person's name is CP. I think it's just CP he showed on, I hope he's not a commissioner of police before the guy will catch me. Okay? Yes. So please, let's go back and then let's read these things again. Let's refer back to the presentation. I hope the recordings will be there. They're all available. And then the slides should be able to guide us on some few things. And then the most important thing is you need to practice these things over and over. It is the practice that makes us perfect. We won't get it on just one or two times. Please, let's go back, use these things very often. I believe you're going to see a lot of difference in your practice. Yes. Any other question?
Prof, please, on a final note, something just occurred to me.
Yes.
Okay. Are we going to be safe if we should narrow down our diagnosis, whatever be the presentation, to non-specific low back pain as a diagnosis, or mechanical low back pain as a diagnosis? So how does it appear in practice?
Yes, in
saying
practice.
That once somebody has.
In practice, please, I want us to bear this at the back of our mind. If your patient is not in this 80 to 90% of people with non-specific low back pain, please note that this patient requires referral. Your conservative management are not likely going to help the patient. The first 5% of patients are patients with serious spinal pathology. Completely, they cannot help, you can't help them as physiotherapists, because these are patients with cancer, fracture, and all that. So you send them to where they belong to. The other 5% are those with nerve affectation, somebody with a complete nerve compression. Patient cannot do, does not have more than power 1 or power 2. You can see whatever you will do will less likely make the patient come out of the compression. So please ask the patient to go see their surgeons, let them fix it, and then they come back to you. Now, the majority of our patients are going to be the non-specific low back pain. And when you see them, you can work on them and categorize them into this broad spectrum, where we say the disc pathology or the degenerative of the spinal stenosis. So you should know that all degenerative spine diseases are under spinal stenosis. In terms of the arthritis and others, they're all under spinal stenosis, while the disc problem is there as a disc pathology. If you go back to that slide of today, you see some of the MRI I shared, you're going to see the difference between a disc pathology and that which is not a disc pathology, even though there's a compression at the spinal canal. So please, you look at that and try to understand it more frequently. I hope I will also have an opportunity to come and discuss differential diagnosis one day, looking at how to read MRIs and all that. So we'll have a broad understanding of this subject. Yes. So I thank you guys. Okay. Any other observations or comments?
I have a question.
Okay, please go ahead.
Okay, so when you were talking about the VOP and TOP, my network was fluctuating, but you were trying to say something about when it radiates to the lower limbs. I didn't really get that part.
Yes, I said usually the VOP, which is the vertical oscillatory pressure, is more commonly used with spinal stenosis, where the symptoms is usually bilateral. So you go straight on the spinal process and you push straight down. And it's just like the central posterior anterior movement. So, but when you use the TOP, which is a transverse oscillatory pressure, it's usually a unilateral affectation. So if it's a unilateral affectation, you're going to stand on the affected side of the limb, and then you move it in the opposite direction, okay? So that it's going to go the other way, so moving away from where the compression is. So that's the TOP. So I think those are the things I mentioned over there.
So what I'm asking, you were saying something about if there's pain on the limbs, like you're not getting it right. I don't know if I heard that correctly.
When you're doing the movement, whether VOP or TOP, when you're doing the movement and the pain is peripheralizing, it means it's a wrong movement. The patient either did not give you the correct description of the pain, then you should know that your movement is compressing the nerve roots the more. Because a pain that the patient has in the buttocks is now going to the thigh, or is going to the calf muscle, or is going to the foot. That tells you that movement is a wrong movement and you should stop it. Okay? But when you are moving, you are doing the movement and the patient tells you that I'm not feeling any pain now in my calf muscle, the pain has moved to my buttocks or is in my back, and it's even worse in my back. So I said that is a good news, because that's a centralization phenomenon, even if the pain has increased.
Okay, so does that mean we shouldn't use, like when a patient complains about a radiating pain, could we still use VOP and TOP for our treatment?
That's the essence. We need to use them. Well, but I'm telling you how to use them and the sign to watch out for during using them. Okay? If you are using it, yes, if you are using it and then the symptom is centralization, beautiful, good news, then you should use it the more. You should increase it. Okay? But when you are using it and then the pain is peripheralization, or the symptom is peripheralizing, it's going downwards, I said it's a bad sign. You should stop it. You should change that movement. Yes.
Okay, the last question. Papa was the one that asked about that you should please rephrase what you said about the exercise and the stages in low back pain.
Exercises and what?
And the stages in low back pain. Where you were talking about the acute, subacute, and chronic, the different things to do at those stages.
Yes. Like I mentioned, I said at the acute stage, the exercise should just be minimal abdominal brace, gluteal contraction. So it's just for you to control the pain. You shouldn't do any movement that will provoke the pain. So in the middle stage or subacute stage, That's when you begin to move to some extent. And the chronic stage, you want to do full movement and functional movement. And of course, the intensity of your exercises, I have a slide there that will guide you. Please, the coordinator of the program is going to share the slide with you after this.
All right, sir.
Okay.
All right, thank you, sir. That's all.
Thank you. I'm very happy because I've learned a lot from you guys, especially Nelson, all of you that participated. It has been a pleasure. You've given me opportunity to also learn from you, and I want to appreciate you. And I hope in the nearest future we'll still have time to interact again. I thank you once again for coming to the program, and I hope it's going to make us a better physiotherapist in the future. Thank you for staying. Have a wonderful evening. Bye for now.
Thank you, sir.
Thank you, bro.
About South.
Thank you, Prof.
Space. Where you take the wash?
I'm sure to thin out. kun je kun shirya ne? Me za ku dauko? Ku je ku shirya kayan ku.